Ma'am, we are live and you can start.
Good morning, everybody. Welcome to the second day of the Digital Satellite Symposium conducted by the Endocrine Society of India East Division. As you know, we are dealing on the topic of tropical endocrinology. Endocrinology in the tropics at times behaves a little differently because of numerous factors like nutrition, food habits, infections, and so many others. We had a delightful evening yesterday where we discussed so many problems, starting from hemoglobinopathies to bone disorders and amongst others. We also have a number of sessions lined up today. To take you through this, we have we are very ably led by our chairpersons. So to start off with the first session on FCPD, I would like to introduce the first chairperson of this first session, Dr. Uma Kaimal Saikia. May we have the CV slide, please? Dr. Uma Kaiman Sekia, who's also been my teacher and guide during my DM days, is presently associated with Guwahati Medical College, Assam. She's the head of the division of endocrinology there. Dr. Saikia has immense experience, including various programs, and has contributed and participated in different programs for different diverse fields of study. Her research interests reflect in her wide range of publications in the various national and international journals. She has over 34 scientific publications in international and national journals. I would hand over this stage now, the digital stage now, to Madam to take it forward from here.
Thank you, Arundhati. First of all, a very good morning to all of you. And I thank the organizers for giving me this opportunity to chair this first session on FCPD, that is fibrocalculous pancreatic diabetes. As we are all aware that this FCPD is a type of diabetes which is peculiar to the tropics. And in India, the maximum number of cases were reported from Kerala, Tamil Nadu, Orissa, and the Northeast. And over the years, though first reported in the early 1960s, the famous publication by Givarghese et al. After that, it has been reported from various other parts of India also. And though originally described as a diabetes which was supposed to be associated with malnutrition and the cassava hypothesis, over the years, we have got newer ideas and regarding the pathogenesis of this disease, regarding the genetic factors responsible, and there has also been a change in the pattern of FCPD, which we are seeing. So to take us through this interesting topic, we first will have a case presentation, followed by a talk by Professor Nihal Thomas. So may I have the first, the introduction of Dr. Krishna Prabha will be presenting the case, I think. Can we have the intro?
Good morning, ma'am. Am I audible?
Yes, you are audible.
Can I share my screen, ma'am?
Yeah, please do.
Yes, please.
Is my screen visible, ma'am?
Yes, it is visible. You can start.
First of all, I would like to thank the Endocrine Society of India East team and my teachers for giving me an opportunity to present this case. This is the story of a 54-year-old gentleman who hailed from Kerala. He's from a rural background and he works as a rubber plantationer. So he presented to us with upper abdominal pain, which was radiating to the back since the last 1 year. He was having similar such episodes since the last 3 years, but this time it was persisting and his pain was relieved only by sitting up and stooping forwards. He had a weight loss of around 10 kg since the last 6 months, and he also gave us a history of steatorrhea, which usually increased after the intake of a fat-rich meal since the last 6 months. He had a history of diabetes mellitus. It was detected at the age of 44 years, and he was on regular treatment with oral anti-hypoglycemic agents, including metformin and a sulfonylurea. He admitted to being very poorly compliant to his diet as well as medications. He hailed from a middle class rural background, and usually they prefer carbohydrate rich diet in those areas with a rich intake of roots and tubers. But there was no history suggestive of any micro or macrovascular complications of diabetes mellitus. There was no history suggestive of any diabetic ketoacidosis. And there was no history of any night blindness or bleeding diathesis. There was no family history of diabetes mellitus, and he was not a smoker, nor did he consume alcohol. He was married, he had 2 children. So on examination, we found him to be in severe pain. He was emaciated. His body mass index was 20.5 kg per meter square. His vitals were stable. There were no palpable lymph nodes. He did not have any evidence of any insulin resistance. There was no acanthosis or skin tags, and no evidence of any nutritional deficiencies like bitote spots. His abdominal examination did not reveal any abdominal mass. There was no hepatosplenomegaly. He did have severe epigastric tenderness on palpation. So going to his blood biochemistry, we found that his hemoglobin was normal. He had an elevated HbA1c of 10.5%, suggestive of poor glycemic control. His electrolytes were normal. His corrected calcium phosphate albumin were normal. His 25 hydroxy vitamin D was on the lower side. His lipid profile was also normal. He did not have any hypertriglyceridemia. His triglycerides were 72 milligram percent. His LFT was essentially normal. We also found that his stool elastase was on the lower side. It was 100 microgram per gram. It was suggestive of an exocrine pancreatic insufficiency. His carbohydrate antigen 99 was significantly elevated. It was 943 units per ml, which is suggestive of some GI malignancy. So this was his X-ray abdomen, and his X-ray abdomen in fact showed multiple calculi at the level of the second and third lumbar vertebrae. And we proceeded with a CT abdomen. The CT abdomen in fact showed diffuse bulky pancreas with dilated main pancreatic duct with a diameter of 12 millimeters, and that showed bulky chunky calcifications both intraductal as well as parenchymal pancreatic calcifications, as well as there was a hypodense lesion at the head of the pancreas measuring 4.4 into 3.4 into 3.3 centimeters. We proceeded with an MRI upper abdominal cuts, and this revealed a T2 hyperintense exophytic lesion at the head of pancreas, suggestive of a malignancy. Hence, we made a diagnosis of fibrocalculous pancreatic disease with carcinoma head of pancreas. And we went ahead with an endoscopic ultrasound guided FNAC, which confirmed a poorly differentiated adenocarcinoma of the head of pancreas. There was a multidisciplinary team meeting held with the patient relatives. We explained regarding the treatment options for the same. The Whipple's procedure, pancreatoduodenectomy, was explained to him, but he declined surgery. He was started on chemotherapy with gemcitabine and albumin-bound paclitaxel. And his diabetes was managed following with insulin basal bolus regime, and we started him on enzyme supplements for his exocrine insufficiency. Thank you, ma'am. Thank you.
Ma'am, you're muted.
Thank you, Dr. Krishna Prabha. We'll now go on to the next talk by Professor Nihal Thomas. Professor Thomas doesn't need any introduction for this audience. He's a professor in endocrinology and head at the Department of Endocrinology, CMC, Vellore. And he is currently associate director at CMC. He has more than 220 index publications, including several areas of endocrinology. He has also authored various chapters in textbooks. He is a reviewer in many important journals, especially clinical endocrinology. He has run more than 60 multinational and in-house designed clinical trials. He was the organizing secretary of the annual conference of Endocrine Society of India, which was held at Vellore in 2010. And he has an active research network with many overseas universities also. And he's an NCORE faculty member at the Melbourne University. So I request Professor Thomas to kindly start his talk.
Good morning. I hope I'm audible to all of you. Thank you for that introduction, Dr. Uma Saikya, and thanks to the organizers for inviting me to give this talk. Krishna, thank you for that explicit presentation. So I'll be talking to you about the aspect of fibrocalcic pancreatic diabetes. But since we have an August panel who will be discussing many aspects with their questions which are being asked of them, I will deal with a few aspects and I will not touch on some of the other aspects which may be overlapping with the basics of fibrocalcic pancreatic diabetes. So I'll be focusing on some of the clinical features and the background of the disorder, the variability in pancreatic size, other genetic conditions which mimic fibrocalcic pancreatic diabetes mellitus, some advances into hormone physiology, and finally, the therapy. So it's all started perhaps more than 70 years ago, and without alluding to this slide, I should mention that the first postmortem study which diagnosed fibrocalcic pancreatic diabetes was at Vellore in the year 1954. And of course, subsequently, the first cases were reported from Indonesia. And of course, you can see quite clearly that the distribution of the disorder is essentially absolutely tropical between the tropics of Cancer and Capricorn, but for a few areas in South Africa and perhaps in Argentina. If you look at the clinical features, and as the case had mentioned, it is classically described as abdominal pain in the first decade, which is often under-recognized and may in children very often be wrongly attributed towards worms or a psychogenic abdominal pain, maldigestion leading to steatord, which can be detected ideally with a 72-hour stool fat, which is a test which is moving out of vogue now and using elastase levels in stool to be measured, and preceded by a phenomena called tropical pancreatitis, wherein the individuals are invariably lean and have a low BMI, generally less than 20 kilograms per meter squared. The diabetes, when it develops, is called fibrocalcic pancreatic diabetes with low to moderate insulin requirements, and there's a 40% risk of pancreatic carcinoma from the fourth decade onwards, provided they do not succumb to the onslaught of the usual microvascular, macrovascular complications added to the malnutrition that they face with the malabsorption that they have. So critical for diagnosis, besides the fat malabsorption, is ruling out other conditions wherein you have insulinopenic diabetes, the C-peptide levels are low, and an ultrasound or a CT abdomen beyond that with plain X-ray of the abdomen is useful to show the classical duct dilatation with chunky calcification and intraductal stones. So what I would like to herald over here is that a number of patients who come are underdiagnosed because people do believe that the prevalence is declining, particularly in some of the southern states, but it's still very much there. This is from our own database with lean diabetes mellitus, 20 kgs per meter squared. When they were referred to us for treatment, they had not been screened previously. And without a pancreatic imaging and a GAD antibody, we found a number of patients, in fact, who had fibrocalcic pancreatic diabetes, only second to underdiagnosed type 1 diabetes mellitus. Now, the important aspect is to differentiate it from the more common form of pancreatitis and the alcoholic chronic pancreatitis. And this list was published about 2 decades back by the group from Chennai. And the alcoholic pancreatitis, of course, in Indians is largely in males, has a later onset from fibrocalcic pancreatic diabetes and is generally more well distributed across social strata. The course of diabetes is much slower in alcoholic disease. Diabetes occurs, of course, almost invariably in the fibrocalcic pancreatic diabetes group. And pancreatic calculi are large and are usually very dense without the speckling that alcoholic pancreatitis has. The duct dilatation is generally marked. There's fibrosis of the gland, which tends to shrink the pancreas much more. And there is, of course, a potential for overlap between alcoholism and this form of pancreatitis in addition. And of course, the prevalence of malignancy is extraordinarily high. So if you look at the mutations which are associated with primary exocrine dysfunction, these are the ones which I would like to highlight. The SPINK1 mutation, serine protease inhibitor Casal type 1A, the PRSS1, which has an impact on the cationic trypsinogen, therefore inducing an octoactivation of digestion within the pancreas. And of course, the cystic fibrosis transmembrane conductant regulator, which is definitely there in India, but perhaps a little less common than the other two. So what happens by and large is an autodigestion phenomena which occurs. And you can see over here that the activation, as you can see over here, mesotrypsin, trypsin effect is lost. And with the mutation of SPINK, there's an increased production of trypsin, enzyme cascade, and subsequent autodigestion with pancreatitis. Now, this is our work on fibrocalcic pancreatic diabetes, looking at those who had fibrocalcic pancreatic diabetes who were SPINK positive versus SPINK negative. And we find over here that many of the variables are similar. Having said that, there are differences. The stool fat excretion rates were higher. This is a 72-hour stool fat in those who had SPINK mutations. Insulin secretory rates were also worse. And glucagon secretion was more or less the same. Having said that, statistical significance-wise, it was less in the SPINK1 mutations compared to the ones who were SPINK negative. And more interesting is that the insulin resistance at the level of the periphery was higher in those who were SPINK negative. So basically, we have exocrine dysfunction in the SPINK positive patients, poorer insulin secretion, and greater peripheral resistance. Now let's focus on another aspect, the aspect of pancreatic size. And I'm not talking about fibrocalcic pancreatic diabetes here, but there is definitely a shift towards a change in pancreatic size, even with other disorders, much simpler than that of fibrocalcic pancreatic diabetes. So there is a minimal reduction in pancreatic size with type 1 and type 2 diabetes. And if you have an oversensitive radiologist, this may be actually picked up, though is not that clinically discernible. With insulin usage and the presence of pancreatic insufficiency, the pancreatic size is negatively correlated. But it is positively related to body size, both on imaging and autopsy studies. If you look at this particular table, which was published in an article in Nature Genetics about 10 years back, it tells you quite clearly here in terms of the correlations with pancreatic size. And of course, there's a more profound decline in pancreatic size with a long duration of type 1, a little less with type 2 diabetes as they become elderly. Fat content on an MRI SPECT is increased with increasing body weight and an increase in type 2 diabetes, but in type 1 diabetes, there is no change. Calcification is not a feature, and the ultrasound reflectivity is increased with age and with body weight. So these are important things to know in the background to prevent false positives or false negatives in this situation. And I shall allude to the correlation with pancreatic diseases on the rest of this table as the talk goes on. So there are other genetic conditions which mimic fibrocalcic pancreatic diabetes mellitus. And these include several mutations which form the monogenic disorders which can cause diabetes. I've listed them over here, but I would particularly like to talk about the HNF1 beta and the CEL mutations. These can actually lead to pancreatic body and tail aplasia and also increased fat deposition within the pancreas. For HNF1 beta, it's more an aplasia, and for CL, it's more for lipomatosis. So just reminding you that the carboxy is the lipase mutation, or is in fact MODY8, and mutations in this gene can cause pronounced fibrosis, as you can see here on the histopathology, and acinar cells are actually not visible over here, nor are the beta cells. And over here, you can have a CT scan of this patient. As you know, it's autosomal dominant inheritance. Some members may have endocrine insufficiency without diabetes. And in both these, you can see a very prominent splenic vein. So there is obviously an increased distal runoff of blood over here. And what is prominent is actually the pancreatic lipomatosis and not calcification. MODY type 5, which is a multi-system form of MODY, besides young onset diabetes, can have renal cystic disease, uterine anomalies, problems with the genitourinary tract in both males and females, and of course the pancreatic anomalies as well. And this over here, once again, I'm showing you the CT scans and the MRIs of patients with MODY for type 5 mutations. Now, what you can see in all these cuts is that there's virtually no pancreatic tissue in the region of the body and the tail. All right. And in addition to that, there is a very short pancreatic duct, as you can see over here. A very short pancreatic duct is present, but there's no ducts corresponding to the body or the tail of the pancreas. So this is extreme MODY 5. Not all patients will have this, but this is something you should look for. And they can obviously have malabsorption, and this can be mistaken for fibroclastic pancreatic diabetes, though calcification is not a major feature over here. And even in CL, it's more lipomatosis with a smaller pancreas rather than calcification or duct dilatation. But both can have malabsorption and fat excretion problems. Here, comparing between the two types, the CL mutations and the HNF beta mutations, you can see the gross difference: lipomatosis in the CL, duct dilatation and calcification. The absence of the pancreatic head in the patients who have underlying HNF1 beta mutations. So you can see the lipomatosis, which is very profound over here. And then we talk about the neonatal forms. Now, these other two which I mentioned, the CL and the HNF1 beta, occur in adolescence to adulthood to childhood, whereas these are largely neonatal presentations and very occasionally can present in adolescence as well. So the FOXP3 can cause mild pancreatic atrophy. The EIF2AK3, which is autosomal recessive, can cause severe pancreatic hypoplasia. We've already talked about HNF1 beta. And then you can have the PTF1A, which can cause pancreatic agenesis. The pancreatic homozygous box mutation, wherein you can also have, is also a MODY, basically a MODY4. Pancreatic agenesis, no body or tail in the homozygous patient. The heterozygotes, they actually have pancreatic mass and can be managed with oral antidiabetic agents. And hypoplastic granular pancreas in the RFX6, autosomal recessive, and the GLIS3 mutation comes later in life and has small pancreatic cysts, but can mimic type 2 diabetes. So coming back to the table which I showed you about pancreatic size, in general, there are big differences between each mutation, but monogenic diabetes mellitus unchanged or agenesis in these, depending on the type. Fat content may be increased, but in advanced chronic pancreatitis, on the other hand, there's no increase in fat content, and the size of the pancreas is, of course, reduced. Calcification may or may not be present in on the monogenic forms, and ultrasound activity is attenuated without calcification in patients with monogenic forms. So let's have an algorithm. If in case, now we need to have a sensitivity of picking up these cases when they are there and thinking of other genetic conditions, which we haven't possibly been doing for a very long time, we should include this algorithm: pancreatic apoplasia, hypoplasia, and annular pancreas. Think of these mutations and do an NGS, next generation sequencing, to pick up these mutations. And the management and the prognosis changes. With a normal pancreas, think of the standard MODYs. Pancreatic hypoplasia and lipomatosis, think of HNF1 beta and CEL. And also one more I'd like to throw in is the mitochondrial mutations, which can cause recurrent attacks of acute pancreatitis and calcification, eventually with malabsorption. So let's end with a bit on some of the advances in hormonal physiology. And this work was done at our center in CMC. And a lot of it was supervised by my colleague, Dr. Riddhidas Gupta. And in addition to that, we had collaborations with the Albert Einstein University in the United States of America. So we had several questions in terms of what was the pathogenesis due to. Was there an insulin resistance component? They do not develop ketosis, so was there something else to it? What about the glucagon secretion? Was there any other issue? And so basically, we looked at a combination. We compared type 1, type 2, Fcpd and other forms. We looked at only male subjects, and we did hyperinsulinic euglycemic clamp studies. We did this very extensive pancreatic clamp to study these individuals. We, as you can see over here, I'm not going into the details, but we measured levels of glucagon. We also injected somatostatin growth hormone and glucagon at the start, which is called a total pancreatic clamp. We also looked at indirect calorimetry and NMR spectroscopy. And these were the findings. We found that the lean mass was obviously much lower than that of type 2 diabetes. The hepatic fat content and muscle fat content were very similar to type 1 diabetes, and of course much lower than the other forms. When we looked at insulin and glucagon, and these are the key findings, the insulin levels were low, but not as low as type 1 diabetes. You see the two parallel lines at the bottom. The glucagon levels in pancreatic diabetes were elevated compared to that of type 1 diabetes, and in fact were higher than the phase of tropical pancreatitis. Insulin sensitivity, there was hepatic resistance present in fibroclastic pancreatic diabetes and mild peripheral resistance in addition. So in summary, patients with fibroclastic pancreatic diabetes on a longer duration of diabetes do have insulin resistance, increased glucagon secretion, and this seems to correlate with the peripheral resistance. So why is the glucagon high in spite of a fibrotic pancreas? So there are studies to show that in human beings, when the pancreas is taken off, the glucagon levels rise. And this is probably due to an upregulation of the pre-pro-glucagon genome, which is there in the L cells, which also produce GLP-1. And we hypothesize that it's probably coming from an ectopic source. So we next checked the other hormones, the hormones from the L cells in the intestine. And we did find, interestingly, that the GLP-1 levels were elevated in these patients, and the oxyntomodulin levels were also elevated along with the glucagon levels. So it indicates that there's probably an L cell overactivity in these patients. So in summary, basically this is the whole picture. High glucagon, high GLP-1, oxyntomodulin, suppress C-peptides and suppress pancreatic polypeptide. And therefore, we believe that the origin is from the L cells. We also found that the energy expenditure was extra high, which is an indicator that the carbohydrate intake should be very high in these patients, because beyond that of trying to build up their bodies and also compensate for their malabsorption that they have. You may have to give very high dietary requirements of 2,500 to 3,000 calories per day. Therapy-wise, very briefly, the insulin doses are around 0.3 units per kg per day. They are more prone for hypoglycemia, and we have done work to show that autonomic dysfunction is present in about 65%. Pancreatic enzyme supplementation is mandatory and should not be forgotten, and therefore increase the insulin dosing thereafter. And of course, finally, propensity for pancreatic carcinoma. I'd like to thank my entire department and many people who have worked on various aspects of this, and all our funding agencies in addition, and our collaborators. Thank you so much.
Thank you, Professor Thomas, for your excellent talk and your in-depth research on this topic. You have basically stressed on the importance of diagnosis and the differential diagnosis which should be considered when we are seeing patients with, when we suspect this condition, the differentiation, say, from type 1 as well as other genetic forms. And the very interesting part about the hormonal profile, the classical teaching that they don't develop ketosis because they have no glucagon. And that has been refuted by seeing that you have got higher levels of glucagon. So, could you, in spite of this, why do you think that they don't develop ketoacidosis in spite
Thank
of?
you for that. So there are probably multiple reasons. Um, one of the facts is that they also have insulin levels which are low, but not as low as that of type 1 diabetes. So that may be one of the reasons why this happens. The second reason is, though we have not proven that, is that they may have other micronutrient deficiencies as well, which are important for the precipitation of ketoacidosis. And carnitine deficiency is one such uh, analyte which people think which may be responsible. So there are studies which have shown that carnitine deficiencies levels may be borderline low in patients who have chronic pancreatitis as well. On doing a dietary analysis of these patients, we found that a number of other micronutrients were also deficient, partly due to fadism in terms of what they eat, and partly due to the fact that they basically do not have a balanced diet from wherever they come from in addition. So these are a couple of the theories as to why keto. Having said that, it is not that ketoacidosis does not occur, it's uncommon, but we have seen a couple of patients with classical fibroclastic pancreatic diabetes developing ketoacidosis.
Thank you, Professor Thomas. I think we go on to the panel discussion because this topic will be discussed fully with the different panelists also. So I request the moderator, Dr. Nitin Kapoor now. I hand over the mic to him to carry on the session.
We will introduce Dr. Nitin Kapoor. Could we have the CV slide for him, please? Yeah, may I ask the organizing team to please flash the CV slide for Dr. Nitin Kapoor? So, yes, right. So to take you through the panel discussion on FCPD by a very distinguished panel of doctors that we have lined up, we have Dr. Nitin Kapoor, who's presently the Professor of Endocrinology at CMC Vellore. Dr. Nitin has completed his DM and postdoctoral fellowship from CMC Vellore itself, and he did his PhD research on obesity from the University of Melbourne, Australia. He has been conferred with the prestigious AR-SET Gold Medal by the ESI 2020, the Young Investigator Award by the Sri Lankan Endocrine Society 2019, Melbourne Research Scholarship 2016 to 2020, Tamil Nadu Dr. MGR University Gold Medal in Endocrinology 2015, AV Gandhi Award 2014, IGM Award for Excellence 2014. Wow, that's a long list. And he has more than 130 indexed peer-reviewed publications in national and international journals. And his key areas of interest are obesity, metabolic syndrome, pituitary disorders, and metabolic disorders. He's also spearheaded the write-up and is the editor of the current and the previous edition of the book, A Practical Guide to Diabetes Mellitus. So I hand it over to you, Dr. Nitin Kapoor, from here onwards.
Right. Thank you so much, Arundhati, and thank you, ESI, for that very kind invitation. Could I request for the CV slides to still be on? I would like to introduce the panelists. So we have a very distinguished panel discussion with 4 senior endocrinologists. Our first panelist is Dr. Abdesh Kumar Singh. I think he needs no introduction to this audience. Very experienced senior endocrinologist of our countries, is a consultant endocrinologist at GD Hospital and Diabetes Institute in Kolkata. We also have amongst us Dr. Dayaniti Meher. Dr. Dayaniti is Associate Professor of Endocrinology at Kalinga Institute of Medical Sciences in Bhubaneswar. A lot of achievements, total clinical experience of 12 years and over 20 publications in national and international journals. We also have with us Dr. Pranab Kumar Sahana, so is faculty at the Department of Endocrinology at NRS Medical College, Kolkata, West Bengal, over 4 years of teaching experience. and several honors and achievements, over 43 publications. And we also have with us Dr. Neeraj Sinha. Dr. Neeraj Sinha is a consultant endocrinologist at this hospital in Patna, and was the assistant professor at IGIMS Patna. Again, several honors and achievements and publications as first author. So with this very distinguished panel, we have about 25 minutes to take everyone through this panel discussion, for which we've planned several questions covering across the spectrum of fibrocalculus pancreatic diabetes. So without wasting further time, we'll go on to the first question. And if I may ask Dr. Abdesh Kumar Singh, sir. So from your vast clinical experience, if you had to give a message for all the listeners today, all the practitioners here, when should they in their clinical practice suspect FCPD? Dr. Abdesh Kumar Singh, sir.
Thank you, Nitin. Thank you, ESI. Thank you, organizing committee, for inviting me. I think Dr. Krishna Prabha and Dr. Nihal has already went through a typical case, except, only a typical thing in that particular case was he has almost in fifth decade. So, the classical presentation of FCPD, what we learned over that, it would be a typical young adult or adolescent having a picture of malnutrition, emaciation, with a lean BMI, history of chronic abdominal pain, plus minus history of steatorrhea, depending upon what the patient eat. And, a typical presentation of having a pretty high blood sugar without ketosis. So, in clinical practice, when you find someone, irrespective of the age, in fact, if you find someone with a normal to lean BMI and having a pretty high blood sugar, and in absence of a frank ketosis, I would suggest that that is a classical way to look into and to suspect a pancreatic diabetes. This patient typically may not have a history of chronic abdominal pain or steatorrhea, because steatorrhea is basically what you eat, and that's the manifestation depending upon. So that's the classical presentation. But, as discussed, typically it's happening in young, history of malabsorption, chronic abdominal pain, plus minus steatorrhea. And blood sugar might range from, depending upon in which stage you caught the patient. We will come to those stages of diabetes. So that's the classical presentation of FCP. Nitin? It looks like we have lost Nitin.
Yes, ma'am, would you please take over? And
So fine. I think Dr. Nitin has lost connection. So maybe we can have the next slide of questions. Would that the next question slide be available?
Nitin has joined now, it looks like.
Yes, Dr. Nitin, we had lost you, your connection, I think. Yeah. You are muted.
Are you able to hear me now?
Yes, yes.
Yeah.
So with this, thank you, sir, for that answer. And with this, for the benefit of postgraduates who are listening here, sir, if you could answer the question as to how would they classically describe the 3 stages of FCPD, a question that is sometimes often asked in exams. So how would you?
Yeah. Well, so, these are arbitrary staging of FCPD, which was done perhaps almost a decade ago. But then, classically, these stages are, you might get a case of FCPD in a stage where patient is. Hello?
Yes, sir.
Yeah, I think I'm getting muted by the host. Well, so classically, there are three stages of FCPD. You might catch a patient of FCPD when patient may have mild to no hyperglycemia. These are typical case of uh, patients having chronic abdominal pain and with in a stage of either impaired glucose tolerance. Classically, we called as a tropical calcific pancreatitis. So that's the stage of TCP. The second, you get a stage of frank diabetes without obvious ketosis, and third stage could be with advancing age. You might get these patients in a very classical brittle case of diabetes, landing with hypoglycemia with a very small dose of insulin and associated complications. But then these are not a validated staging of FCPD. These are all arbitrary classification. But this is how you classically it presents with. Initially, it goes with pre-diabetes stage and followed by frank diabetes in absence of ketosis. Then it goes to frank diabetes with having a brittle mode going into hypos and hyper. And finally, you might end up these patients with complications of diabetes. Interestingly, FCPD, I'm sure in the next sets of questions it will come. These patients typically may have any complications of diabetes, and as Dr. Nihal presented, they have more often have autonomic dysfunction for various reasons, but typically they don't exhibit, classical tendency of having a cardiovascular disease, unlike of type 2 diabetes for various reasons.
Thank you, sir. So with this, I think the message is clear. When we are in our clinical practice suspecting FCPD, we are looking at lean individuals with high blood glucose, less propensity for ketosis, with history of steatoria and exocrine insufficiency, abdominal pain. Thank you, sir, for making that clear. And this I move on to the next question. And my next question is for Dr. Nidhi Meher. And in trying to understand the epidemiology of FCPD, and Dr. Nihal did show a brilliant map, world map, and it was seen that it is classically seen in tropics. So if I may ask Dr. Dayanidhi, from your reading, what would you say that which countries are more affected with respect to FCPD? Dr. Dayanidhi? So we cannot hear you.
Yeah, thank you, Nitin. Yeah, as the name suggests, this disease is particularly found in peri-equatorial tropical countries like India, Sri Lanka, Bangladesh, Thailand, then your Malaysia, as well in African countries like Uganda, Jamaica, and also in countries like Brazil and Argentina. And also and recently it has been found also in China also, has also been described in China also. There are descriptions from South Africa as well as from Japan as well. But more or less these are prevalent in countries which are in the peri-equatorial region of the tropical countries in the peri-equatorial region.
Right, sir. And so very apt for this particular meeting on tropical endocrinology. And my next question to you, sir, would be for the knowledge of our audience. What would you say is the prevalence with respect to the Indian scenario?
Yeah, again, in India, it is more common in states like Odisha, Kerala, Tamil Nadu, as well as in other states. But the prevalence, as described in various prevalence studies, has been quite heterogeneous. For example, in Odisha, most the patients who were admitted in endocrinology and gastroenterology ward, and were in a 20-year data, it was found that the pancreatic diabetes consisted of 3.7% of the total diabetic population, and in the age group between 30 to 40, the prevalence was 10%. It is quite high in comparison to any other prevalence studies. Similarly, in a study, in the prevalence study from Chennai in 2008, the prevalence was 0.36% in the self-reported cases of diabetes. However, in the general population, it is 0.019%. Similarly, in Kerala, in early 90s, the prevalence described was 0.125%. So this again varies from different states in India also.
And as you rightly mentioned, it does depend on the kind of center, a tertiary care center, bias.
And again,
all that.
from SGPGI, when 105 patients were studied over between the ages of 18 to 35, the prevalence of FCPD was 15%, while it was 40% for both the type 1 and type 2. So the prevalence in Indian population is also quite heterogeneous, depending on the studies.
Sure. Thank you for that. And giving it a perspective of a gastroenterologist, when they see a lot of patients coming with chronic pancreatitis, so how many of those patients would actually be FCPD?
Yeah, over the years, the prevalence of pancreatitis, when the etiology of pancreatitis has changed. Initially, in India, most of the cases of pancreatitis were related to this tropical pancreatitis, but because of the lifestyle changes, there are also increasing number of cases related to alcoholism. So, initial studies they show that most of the patients, even more than 90% of the patients, were tropical calcific pancreatitis, but that is changing now. And again, the prevalence of tropical pancreatitis with alcoholism, the presentation is also being more common now. So there is some contribution of alcohol use in early presentation of pancreatitis with FCPD prone patients, and that again varies from studies to studies.
Sure. Thank you for that question, answer. And now I move on to our third panelist, and may I invite Dr. Pranab Kumar Sahana to throw some light on pathogenesis. We did hear about genetics from the previous talk, but what would be your take on the role of cassava and how it was earlier one of the key important pathogenic factors, and how this understanding has changed over time? Over to Dr. Pranab Sahana.
Thank you, Dr. Kapoor. First of all, regarding pathogenesis of FCPD, the exact etiology is still elusive. However, there are different hypotheses regarding the pathogenesis of FCPD. First of all, the cassava. Actually, cassava is consumed as a staple food in several states of southern India. And also, there are malnutrition in those areas. And therefore, earlier researchers thought that cassava could lead to pancreatic damage and pancreatitis leading to diabetes. But later on, it was seen that FCPD also occurs in areas where cassava is not consumed, and also it is not seen in areas where it is highly consumed. Therefore, role of cassava is confusing and controversial in the etiopathogenesis of FCPD. That is the current opinion. And also in animal model, it has not been seen that there is a close relation of cassava with the development of diabetes.
Sure.
Next, regarding role of genetics, there are several genes which have been which has been important in the causation of FCPD. The most important of which is the SPINK1, that is serine protease inhibitor causal type 1 gene. Now this gene encodes a protein SPINK1. SPINK1 is a protein which can inhibit the activation of the trypsinogen 2 trypsin, therefore preventing autodigestion of the pancreas. Now it has been seen there is mutation in the particularly N34S mutation of SPINK1 gene, which is responsible for the FCPD, and there is a high association between mutation of SPINK1 and FCPD, almost to the extent of 40 to 50% association has been seen in different studies. Other genes which have been implicated in the causation of FCPD are chymotrypsinogen C, cathepsin B, CFTR, and cationic trypsinogen. These are the other genes which have some relation with the development of FCPD. And last, malnutrition. It has been earlier postulated that since cassava is consumed in an area where there is also highly prevalence of malnutrition, so therefore malnutrition can be an important causative factor for the FCPD. But however, it has been seen that FCPD is not only prevalent in the areas, in those areas, however, it is also present in areas where there is not much of malnutrition. And also in areas where malnutrition is highly prevalent, like African countries like Somalia, Ethiopia, their FCPD prevalence is not so much high. Therefore, also malnutrition, the hypothesis of causation of FCPD, the exact relation is not clear-cut. However, it could be a promoting factor for the development of hypocalcitic pancreatitis. To sum up, the role of genetics is very important, particularly the role of association of SPINK1 with FCPD is evident, quite clear, evident till now, and other genes also do play a role. And it is also said that it is a two-hit hypothesis of development of FCPD. First hit is some genetic changes, and second hit can also be due to some environmental. To sum up, this is idiopathogenesis of FCPD.
Thank you, sir. I think the clear message is that it is multifactorial and our understanding has grossly changed over the decades. I move on to Dr. Neeraj Kumar and Dr. Neeraj Sinha. We've already heard the answer to the second question as to why they do not develop ketosis, talking about glucagon to the role of carnitine to the insulin levels that are not very low. May I request you to please highlight on the first question. So how in clinical practice the glycemic profile of patients of FCPD is very different from the usual other patients of type 2 diabetes? Dr. Neeraj Sinha. So we cannot hear you.
Yeah, good morning and my sincere regards to all my teachers. Coming on to the question, glycemic profile of patient with FCPD, how is it different from garden variety of type 2 diabetes mellitus? First of all, the similarity is that the diagnosis of diabetes mellitus criteria are same and the need for control of hyperglycemia is similar. And of course, in literature, we have mention of 3 stages where fortunate patient may be identified in pre-diabetes stage, but most of the patients are in frank hyperglycemia. In earlier stages, some of the patients may be managed with oral hypoglycemic agents, but most of the other patients would be requiring insulin for the management of diabetes mellitus. One aspect is the glycemic variability, which is found profoundly in such patient, and it is always in most of the patients it is a matter of frustration that on one hand we have hyperglycemia and on the other hand patient lands up into hypoglycemia. So this it has been seen that postprandial glycemic excursion in patient with FCPD is more than as compared to type 2 diabetes mellitus. And the reasons postulated is the simultaneous loss of pancreatic polypeptide leading on to hepatic resistance, and also there is more of incretin effect loss in such patient. And so this all leads on to the huge glycemic variability. And this is coupled with the frequent occurrence of hypoglycemia. As we increase the insulin doses, there are more chances of hypoglycemia. The reasons postulated again are less glucagon as compared to type 2 diabetes mellitus patient, and that's why patient always switches on in between hyperglycemia and hypoglycemia. But if we talk about hypoglycemia, then it has been seen that if we are able to reduce the glycemic variability, then the occurrence of severe hypoglycemia is even significantly less in FCPD. So yes, they have to be meticulously managed, And the one reason for hypoglycemia is also chronic malnutrition, leading on to less glycogen stored in such patients. So these patients actually, these patients actually require more meticulous education for management of diabetes mellitus, for calorie counting and carbohydrate relation. And one problem what these patients face, that these are mostly coming from low socioeconomic status, mostly patient, not all patient. And so they are more easily lured by advertisement of alternative alternative therapy, alternative treatment modalities for diabetes mellitus. So they are more into suffering of uncontrolled hyperglycemia. So the key would be more of patient education in order to gain better glycemic profile in such patients. And,
thank you, Doctor.
And also very rightly said that they are they do have less ketosis. It has been always observed. And as has been rightly answered, I'm coming to the next question, as has been rightly answered by Sir Dr. Nihal Thomas. And we know that they are ketosis resistant. Most of the patients are ketosis resistant. There are many hypotheses postulated for that. One of the hypotheses was that they do have less of glucagon because of the simultaneous loss of alpha cells. But this concept is now not standing the test of time, and has been rightly found that they are not very much deficient in glucagon.
Sure.
And there are other hypotheses that they do have less of glycogen storage. They do have less of subcutaneous fat. But this subcutaneous fat is again similar to type 1 diabetes mellitus. Then there is the hypothesis that this subcutaneous fat is resistant to liberation of non-essential fatty acid. But again, it was found that when fat is infused in patient of Fcpd and type 1 diabetes mellitus, it was seen that liver is more resistant for ketogenesis. And then there are concepts that there may be carnitine deficiency, and because of which fat does not enter into the mitochondria. And then we have the concept that even after entry of fat into the mitochondria, there are resistance in the further steps of ketogenesis. So we have these much of hypothesis why they are ketosis resistant, but very rightly said that few patients do develop ketosis, and some of them may develop ketoacidosis. In the study done by Dr. Mohan sir, it was found that those patients who are severely found to have low C-peptide, they had more propensity for ketosis.
Thank you, Dr. Neeraj, for that answer. The clear message being that huge glycemic variability that we see, close monitoring, close follow-up is something that's required. So we are running short of time. So may I request the panelists to maybe give a little brief answers. I move on to the diagnosis aspect, and I request again Dr. Abdesh Kumar Singh to maybe highlight overall when we have a classical patient with Fcpd in the OPD, what are the key investigations that we have to send? Dr. Abdesh sir.
Yeah, so basically when it comes to you, they are coming to you because of their uncontrolled diabetes. Because if someone has only chronic abdominal pain without diabetes, they won't come to you. The basic thing is that a young diabetic presenting to you, when do you suspect Fcpd, and when you suspect Fcpd, what you need to do. So of course, this gentleman or young lady may have diabetes, and you need to go for typical diabetes profile like you do for any other diabetic patient. To find the diagnosis, you need to do some radiological examination. So classical way to diagnose, you can go for a plain X-ray abdomen. Dr. Krishna Prabha already shown you this classical case having a calcification at L2, L3 vertebra. So the simple modalities, first to diagnose for pancreatic calculi would be to go for a straight X-ray abdomen. You can confirm it through the ultrasonography. Further, you want to look into the pancreatic pathology, you can go for ERCP, but that's more invasive. You can go for less invasive like MRCP. MRCP gives you additional texture of pancreas and is much more better than even ERCP. So X-ray, USG or MRCP would add into this. Now that is about radiological examination. From the exocrine deficiency part, you could find out, as Dr. Krishna Prabha shown you, that right now the best way to detect is to check for fecal elastase. Classically, when there is exocrine insufficiency, you found the pancreatic elastase to be less than 100 microgram per gram of stool. Ideally, it should be more than 200. Earlier in our times, we used to do 24-hour fat in stool. There are some other, way to find out fat in the stool to detect fat globules, having trypsinogen in the fat and all those immunoreactive trypsinogens and etc. But these all are for research purpose. Now, having said that, you to look into how much is the insulin secretory defect, you need to check the C-peptide. That also will guide you the exact way to treat this patient, as well as potential to having ketosis in the future. So these are some of those investigations related to both endocrine and exocrine part of FCPD.
Thank you, sir. So the key message again being radiology to look at pancreatic calcification, exocrine insufficiency, and looking at the diabetes management. I move on to the next question by our next panelist, Dr. Dayanidhi Meher and Dr. Nihal had already shown a tabular column differentiating alcoholic pancreatitis with fibrocalculus pancreatic diabetes. May I request you to give maybe a one-line message as to what is the key difference between the two?
This is more or less has been discussed. First, we will look at the sex ratio, and the sex ratio, male is to female ratio in tropical pancreatitis is 70:30, while almost all the patients in alcoholic pancreatitis are males. Then age of onset is 2nd to 3rd decade in tropical pancreatitis, while it is 4th to 5th decade in alcoholic pancreatitis. Then socioeconomic status, most of the patients they belong to poor socioeconomic status in the tropical pancreatitis, while alcoholic pancreatitis is found in all strata of the patients. Then coming to the prevalence of diabetes mellitus over the course of time, more than 90%, almost all the patients with the tropical pancreatitis may develop diabetes. More than 90% they do develop diabetes, while diabetes prevalence is around 50% in patients with alcoholic pancreatitis. And regarding the course of diabetes, it is more progressive and aggressive in patients with tropical pancreatitis, while the presentation of diabetes, while the course of diabetes in alcoholic pancreatitis is more gradual. And looking at the pancreas, there is more of fibrosis, more fibrosis in the pancreatic parenchyma in tropical pancreatitis, while it is less obvious in patients suffering from alcoholic pancreatitis. And looking at the calculi in tropical pancreatitis, the calculi are quite large, discrete with discrete margins and are dense, mostly located in the larger ducts, while in case of alcoholic pancreatitis, the calculi are smaller, speckled with the less defined margins, and are mostly located in the smaller ducts. And regarding the likelihood of developing malignancy, the patients with tropical pancreatitis are at a very high risk for developing pancreatic malignancy, while it is less common in patients with suffering from alcoholic pancreatitis. Though in both the cases, the risk ratio is quite high in comparison to the general population.
Thank you so much. So the key difference, the chunky calcification in the ducts in FCPD as compared to the parenchymal calcification. I move on to the next question, and we are running short of time and we'll need to wind up shortly. I think the management of FCPD was covered with respect to the glycemic control. May I request Dr. Pranab to just highlight on the analgesia bit? Like many a times these patients are complaining of recurrent abdominal pain, and what would be your take on the management of analgesia?
So pain is mild, then we can use non-opioid NSAIDs. And if pain is intractable pain, then we have to use opioid analgesic with its proposed side effects also. We have to consider. And if pain is intractable, then patient may warrant surgery also, even surgery. Different surgical procedures have been done already for FCPD, and they are effective, like ductal decompression, like drainage procedures like pancreatojejunostomy, like ablative procedures like partial or total pancreatic resection. So these are different surgeries which can help to alleviate pain in FCPD if pain is intractable. And also gabapentinoid and pregabalin is useful, particularly in neuropathic pain which can develop in FCPD patients. And sometimes plexus block can also help to reduce pain. So these are different modalities of reducing pain in FCPD patients.
Thank you, sir, for that comprehensive answer. I move on to the last question of the panel, and that is with respect to complications. I think we've already heard about the glycemic variability. We've heard about the high risk of adenocarcinoma. May I request Dr. Neeraj to just highlight on the nutritional deficiencies that are seen in patients with FCPD?
Yeah, nutritional deficiency, we know that these patients are suffering from exocrine deficiency, so they are more prone for fat soluble vitamin deficiencies, and they are also likely to suffer anemia due to iron, vitamin B12 and folate deficiency. They are also suffering from protein deficiency. So these all should be addressed, and also these patients are more likely to suffer from osteomalacia because of the vitamin D deficiency. So these all should be taken care of when we are talking about comprehensive management of patient with FCPD.
Sure. Thank you, Dr. Neeraj, for that answer. And with this, we come to an end of the panel discussion, and over to Dr. Arundhati back again. Thank you.
Thank you, Dr. Nitin, and thank you to all the chairperson, the speaker, the panelist, and the presenter for such a wonderful and descriptive session on FCPD. I'm sure our audience must have gained a lot from that. So from here on, we move on to the second session, which is one on snakebite and endocrinology. Though it might appear to some that, this is a very rare problem, but apparently when we were looking at the figures, there were around 1.2 million cases of snakebite in India in the last 2 decades. And interestingly, whatever complications arise, unlike FCPD, which might land, in the clinic of an endocrinologist, a snakebite would not. So it would definitely require clinical precision to judge whether this snakebite has resulted in endocrinological problems by the doctor who is attending to that snakebite patient. So that is why discussion on this is very important. And to take us through, may I please invite our chairperson for the session, Dr. P.K. Mishra. Could we have the CV slide for Dr. Mishra, please? Dr. Mishra is MD in medicine and DNB in endocrinology, and he's an eminent endocrinologist who's practicing at the Capital Hospital, Bhubaneswar. Dr. Mishra,
that was probably a wrong slide. Professor P.K. Mishra is an eminent endocrinologist from the city of Cuttack, and currently is the president of Endocrine Society of Odisha. So over to sir.
Sure, please. Apologies for that.
Sir, you need to unmute.
Take over, Dr. P.K. Mishra, sir. Sir, please unmute yourself.
Yes. Thank you so much. It's a very interesting area in medicine, and particularly tropical endocrinology is a very interesting area in endocrinology. Now, I remember when I was a PG student in medicine in the 70s, I see a snake bite who died in the second week of admission, and autopsy showed adrenal hemorrhage, died of acute adrenal failure. That was the first case I saw in my life, snake bite with acute adrenal failure. Now we have topic on snake bite in endocrinology, and we have Dr. Kamyat. He's a PhD trainee in endocrinology from West Bengal, Calcutta, and he is going to have a case presentation for about 7 minutes, and then we'll have the second speaker, Dr. Sajal Plus.
Dr. Sejal, you can start.
Dr. Sajal Kamath, can you please take over from here? Can you please start? Yeah.
Is my screen visible?
Yes. Start from the first slide.
Yes.
Full screen, please.
Good morning, everybody. I'm going to present the case on snakebite and endocrine disorders. So we had a 31-year-old female patient, Mrs. PK, hailing from West Bengal, who came to us with presenting complaints of secondary amenorrhea since 6 months, with the complaints of fatigue and lethargy for 6 months, and also decreased appetite for 6 months. She was apparently well 6 months back when she developed secondary amenorrhea for 6 months, but she gave us no history of regression of secondary sexual characteristics. There was no history of galactorrhea, no history of headache or visual blurring. There was no history of constipation, dry skin, or cold intolerance. There's no history. She gave us a history of decreased appetite for the last 6 months with lethargy and easy fatigability. However, there was no history of any vomiting or postural dizziness. There was no history of polyuria or polydipsia. In past history, she gave us a history of snake bite, which was a vasculotoxic snake bite according to the documents, 8 months back. She was admitted for the same in a hospital and had AKI, acute kidney injury, during the period, which gradually resolved. The patients also had deranged coagulation profile and bleeding episodes with a documented raised PT-INR, which also resolved during the course of the treatment in the hospital. She has no history of any diabetes, hypertension, or any other chronic illness. Her last childbirth was 8 years back with no history of postpartum hemorrhage during the childbirth, no history of absent lactation, and she had regular menstrual cycles after resumption of the cycles. Moving on to the examination, her pulse was 82 beats per minute regular. Her blood pressure was 108 by 72 millimeter of mercury. However, there was no postural drop. Her height was 160 centimeters, weight 58 kgs with a BMI of 22.65 kg per meter square. Her SMR was B5A present in P5. She had breast atrophy. There was no galactorrhea, no goiter, no dry skin, no hyperpigmentation or hypopigmentation or pale skin. So we got her hormonal profile done, which showed a TSH of 1.02 milli-international unit per liter with a low T4 of 0.75 nanogram per deciliter, and also a low PET sample of cortisol and ACTH with a cortisol of 1.05 microgram per deciliter and ACTH of 6 picogram per ml. Her FSH was also reduced. It was 0.38 milli-international units per liter with an estradiol of 26 picogram per milliliter, with a prolactin of 3.83 nanogram per deciliter and a 25 hydroxyvitamin D3 level of 16 nanogram per ml. We got a MRI hypothalamo-pituitary region of the patient. You can see here there is, which shows an empty sella in both sagittal and coronal section. So we came to a diagnosis of delayed pan-hypopetitism secondary to vasculotoxic snake bite. And following that, she was started on the following treatment: the prednisolone dose of 7.5 milligram per day with 5 milligram in the morning and 2.5 milligram in the evening. A levothyroxine dose of 25 she was started on the levothyroxine dose of 25 microgram on empty stomach, and combined OCPs, overall L, 1 tablet daily with vitamin D supplementation of 60,000 units once a week. So I'm done.
Sir, Dr. Mishra, sir, please introduce.
We have, thank you, Dr. Kumar. We have speaker Devamanya, who is the associate professor of endocrinology in Calcutta, and he is going to present the case for 20 minutes. Dr. Sanal, please.
Thank you, sir, and thank you for the introduction as well as excellent case presentation, which has really started the ball rolling. So I would be sharing my slides. Hope the slides are visible.
Yes.
Thank you, and I would like to thank the Endocrine Society of India as well as the organizers for giving this opportunity. And we have an excellent set of discussions yesterday and today, and this is again a very interesting and rarely talked about aspect of endocrinology, that is snake bite and endocrine disorders. So in India, we have about more than 200 species of snakes, and the 4 species which are the most poisonous and which cause the maximum amount of morbidity and mortality. These are known as big 4. Among them, we have the viperides, which are vasculotoxic, that is Russell viper, and as you can see, the saw-scaled viper. And you have the Elapide, that is the neurotoxic snake bites, and of them, the most famous is the king cobra as well as the common krait. But the Russell viper has a wide distribution across the Indian subcontinent, including India, Sri Lanka, and Burma, where the presence of snake bite is very common, and these complications. So in India, there are more than 200,000 snake bites reported annually with about 50,000 deaths. And snake venom is a mixture of protein, peptides, and carbohydrates. And the effects of the venom depend on the chemical composition, the delivery, the amount which is delivered, and the type of the bite. The neurotoxic snake bites, especially like cobra and krait, have mainly neurological manifestations, whereas viper venom has mainly procoagulant enzymes which activate the coagulation pathway, and this leads to the microthrombi deposition and DIC and activation of fibrinolysis and bleeding. The viper venom also has metalloproteinases, and which is known as hemorrhaging, and this may also lead to damage of the vascular endothelium, leading to vascular leakage. And there is also the viper venom can lead to the damage of and impairment of platelet function. So viper venom basically leads to thrombosis and spontaneous hemorrhage, and this leads to ischemic infarction and hemorrhage in different organs like adrenal and the pituitary. And this infarction is because of DIC and peripheral vascular collapse, as well as spasm of the vessels. And the hemorrhage is, as we have talked about, because of decreased platelet function, decreased clotting factors, as well as fibrinolysis. As you can see here, there is this bleeding in the pituitary stalk in this autopsy sample, as well as you can see in this adrenal gland just above the kidney, you have bleeding in the adrenal gland. And if you see the histopathology out here, there is this fibrin clots along with this yellow colored cells, which are the RBCs as well. So the most common autopsy finding in the pituitary are ischemic necrosis, with hemorrhage along with microthrombi. And the endocrine manifestations can be pituitary and rarely posterior pituitary dysfunction, adrenal involvement, dysglycemia, electrolyte imbalance, and type 4 renal tubular acidosis. Now, the pathophysiology of hypopetitism is quite similar to the pituitary apoplexy in an enlarged gland with limited vascular supply seen in Sheehan syndrome. And there you have the vascular toxicity from the venom, which leads to the capillary leak, which I have discussed because of the damage to the endothelium. There is pituitary edema and swelling. Along with that, the toxins in the venom leads to direct stimulatory effects on the pituitary cells, leading to increased TSH, ACTH, and GH growth hormone. And along with that, with the engorgement of the pituitary, there is decrease in vascular supply because of DIC and induced thrombi, because of hypotension, because of increased ICT. And as we are all aware, there is a compressive effect by the in the sella, and with regards to the capillary leak that leads to more of a compressive effects, and this leads to the acute pituitary damage. Now, there is also a postulated, not yet proven, slow autoimmune damage as well, which is seen akin to Sheehan syndrome, and this is probably auto-antibody mediated slow destruction of the pituitary, and this occurs because of disclosure of the sequestered pituitary antigens by the initial small acute damage to the pituitary. Now, there is both anterior as well as posterior pituitary dysfunction, both acute, as we have discussed, as well as chronic hypopetitism. And hypopetitism is though mainly seen in Indian subcontinent and has been reported as well as Burma and Sri Lanka. Probably it is not very well picked up, and a lot of them are undetected. And this can occur very early, within weeks, acutely, as well as it can be detected very late, about even 10 to 20 years down the line. The delayed hypopetitism, which leads to maybe because of a late diagnosis of acute anterior pituitary insult, or as we have already discussed, maybe because of slow and progressive destruction of anterior pituitary, but it is still not known. The delay in diagnosis and also missed cases may have been because of symptoms of hypopetitism, which are quite non-specific and insidious, and especially in elderly, they may be similar to age-related changes, and also they may be like any chronic ailments. The frequent hypopituitary symptoms which occur are fatigue, weight loss, appetite loss, amenorrhea, reduced libido, infertility, cold intolerance, and loss of axillary and pubic hair, which presents quite late, as well as breast atrophy. So acute pituitary hypopetitism is a rare complication, but it's probably more missed complication. This 30-year-old post snake bite had hematemesis with hypotension. The whole blood clotting time, a marker of DIC, was prolonged. The urine output decreased, and the patient had AKI requiring peritoneal dialysis. There were recurrent episodes of hypoglycemia. So this is very, very important, and that led to confusion, GTCase, tremor, and there was persistent hypotension. That led to investigation of cortisol, which was low, with low ACTH and low thyroid, free T4 and free T3. The PT-APTT was prolonged. The platelet count was also decreased. This recurrent hypoglycemia, hypotension, and shock are very important indicators of acute hypopetitism. Very importantly, the pituitary MRI may be normal, as was found in this patient, but it is very important to remember this acute hypopetitism is mostly persistent and rarely transient. And in a lot of patients, probably it is missed because we are only picking up patients who are symptomatic, and that too, a lot of them are being missed. And generally, we need to be doing more of dynamic testing even in asymptomatic patients. So what are the risk factors which should prompt investigations for acute hypopetitism, which can occur within 2 to 14 days? And this can be because of severe envenomation with multiple organ dysfunction, decreased platelet, and bleeding. But very importantly, probably the most important accompanying feature is acute kidney injury, acute renal failure, and DIC. And if there is persistent unexplained hypotension and hypoglycemia, which can lead to confusion, these are also important indicators. Pituitary hemorrhage on MRI is an important indicator. And as sir was discussing, in adrenal hemorrhage, one can have pain abdomen, hypotension, and also hyponatremia with hyperkalemia. So this was a very elegant study which was published by IPGMR and SSKM Hospital, Kolkata in Pituitary 2019, where they evaluated prospectively patients with snake bite having acute kidney injury requiring hemodialysis, how the factors which predict hypopituitarism. So all patients were tested irrespective of symptoms. Hypopetitism developed very early in 20% of patients, and most of them were diagnosed at baseline. Cortisol deficiency was the commonest, but some rare patients develop even central DI and after cortisol replacement. And hypopetitism was mainly predicted by patients who required more sessions of hemodialysis and who had initial prolonged whole blood clotting time at presentation. So we should be suspicious of hypopetitism, acute hypopetitism in patients who have hypotension, unexplained hypoglycemia, and renal impairment, AKI, and a serum cortisol less than 3 baseline or even 10 may be helpful, or cosintropin stimulated cortisol less than 18 micrograms per DL may be helpful. And as we can see, there is more number of patients detected later on because of progressive damage to the pituitary gland as well. So identification of hypocortisolism is the most important factor in hypopituitarism, and in resource limited settings, as occurs in snake bite, random cortisol less than 10 in critically ill patients may be helpful as per the other Sirki guidelines. And similarly, the delta cortisol, that is increase in cortisol after 60 minutes less than 9, also suggests hypocortisolism. The WHO guidelines suggest and advocate IV hydrocortisone, not IM, in unresponsive hypotension, of course, after taking cortisol samples and then shifting to glucocorticoids once patients are stable. In secondary hypocortisolism, if it is documented along with a low free T4 and T3, we should be starting medications, thyroid medications as well. Evaluation of gonadal and growth hormone axis should be deferred until the patient is stable after 6 to 8 weeks, when we should also try to confirm the presence of reconfirm the presence of secondary hypocortisolism and hypothyroidism as well. But there are some factors which hinder assessment, like critical care, critical illness related pituitary dysfunction, sick euthyroid syndrome, which is very common differential, especially in absence of hypocortisolism. Similarly, hypogonadism in acute illness, and very commonly prior glucocorticoid injection. So the reports may not be interpretable, and also possible pre-existing pituitary or adrenal dysfunction. So again, delayed hypopituitarism may occur after viral envenomation. This may be a continuum of the clinically overt or occult acute pituitary damage, but it may not be preceded by acute pituitary dysfunction. It is actually insidious onset, subtle and non-specific, and can be detected, as we have discussed, even up to 8 to 10 years after snake bite. So that is very important to take the history. And fatigue, weight loss, loss of appetite are general non-specific symptoms. One can have decreased libido and secondary amenorrhea in women. Panhypopituitarism is seen in 80%, hypothyroidism and hypogonadism in majority, along with hypocortisolism even in 75%. What is very important is, though MRI picks up empty sella in 60 to 75% of patients, even with delayed chronic hypopituitarism, MRI is normal in 25%. This is a very important differentiating feature from Sheehan syndrome, where majority of patients have abnormal MRI. And there is no correlation between empty sella and severity of hormonal deficit. Most patients have normal cellular MRI in the first year, as similar to Sheehan. There can be a non-hemorrhagic enlarged pituitary with a thin rim of enhancement. Then the pituitary subsequently atrophies, as we have seen, to an atrophic empty sella by 6 months to 1 year. What is not clear is whether to repeat an MRI after an acute hypopituitarism. And even in chronic hypopituitarism, MRI may not be universally abnormal, though in about 70% one may have empty sella. One may also detect old hemorrhage, and in presence of DI as well, there can be loss of posterior pituitary bright spot. Diabetes insipidus is very rare. This is because anterior pituitary is supplied by low pressure superior hypophyseal artery, which is generally susceptible to compression by increased intracellular pressure, which is seen with the capillary leak and DIC. But this may not be sufficient to compress the posterior pituitary arterial supply, which receives a direct arterial supply from the hypophyseal artery. So polyuria is an indicator of DI, but may be only manifest after we correct hypocortisolism. Generally, it is accompanied, DI is accompanied by, as in this man of 20 years, with hypopeterism and growth retardation and hypothyroidism and hypocortisolism. But rarely isolated central diabetes insipidus have been reported with normal anterior pituitary hormones, and there can be isolated loss of posterior pituitary bright spot with a lower infundibular stalk atrophy with a normal anterior pituitary imaging. Now moving on to adrenal insufficiency, this 28-year-old man presented with sudden lower abdominal pain, vomiting and refractory hypotension. On 4th day after bite, hyponatremia and hyperkalemia was present, and there was documented low cortisol and high ACTH. One very important factor is the diagnosis of adrenal insufficiency is much rarer, but it can be missed in the presence of hypopetitism. And CT revealed, as you can see, bilateral enlarged adrenal with increased density, suggesting bilateral adrenal hemorrhage, which can occur because of DIC, bleeding, as well as circulatory shock. And autopsy studies showed again in patients who have AKI, very important. AKI is a very important indicator for hormonal problems. Adrenal hemorrhage was seen in 36%, pituitary hemorrhage in 43%. Again, adrenal gland is highly vascular, and this etiology of hemorrhage and necrosis is similar to the Waterhouse-Friderichsen syndrome, where adrenal glands are supplied by numerous arteries but drained by a single vein. And so once there is arteriolar dilatation, followed by pooling of blood without adequate drainage because of thrombosis, there can be increased pressure leading to hemorrhage. There have been also reports of combined adrenal as well as pituitary apoplexy as well. Dysglycemia after snake bite is generally seen both in adults and pediatric population, related to degree of envenomation, and it is generally transient, and this is mainly because of autonomic storm with massive outpouring of catecholamines and increase in glucagon and cortisol level. Hyponatremia in hypopetitism is all well known because of hypocortisolism and hypothyroidism, whereas it is also documented in 40% of crate, that is neurotoxic victims. And if fluid restriction is done, it was observed there was severe dehydration. And what was observed along with hyponatremia, there is decrease in serum osmolarity and increase in urine osmolarity with appropriately low ADH levels. So in neurotoxic snake bite, this is basically not SIADH. This is because of direct effect of natriuretic peptides causing hyponatremia. And it has been seen that venom natriuretic peptides have higher potency and stability, and normal saline infusions are required. And this hyponatremia usually occurs by 2nd and 3rd day, and there is raised urinary sodium. But if we are not confident about the chronic hyponatremia, which is more than 48 hours, then slow correction of sodium is essential. Hypokalemia also can occur as a complication of neurotoxic envenomation, which can also complicate the weakness associated with muscle weakness associated with neurotoxic snake bite, which has been reported in Sri Lanka in 71% patients. This can be because of beta adrenergic stimulation from autonomic dysfunction and leading to intracellular shift of potassium, similar to hypokalemic periodic paralysis. And again, there is a potential risk of rebound hyperkalemia later on. And finally, hyperkalemia because of low acute and can present with acute lower limb weakness after viper bite, and this may be associated with mild renal dysfunction, normal anion gap acidosis with inappropriately low urine transtubular potassium gradient, and they respond to fludrocortisone, but fludrocortisone requirement decreases over time, leading to complete recovery. There have been documented cases of hyperkalemia during polyuric phase. This is something which we must be very careful. If we think in polyuric phase there is hyperkalemia will not be there, but it can occur out here, and they may require even dialysis with normal anion gap metabolic acidosis. But the mechanism is still not clear, whether it is because of the venom or because of AKI. Now, the future direction is what we need to investigate is whether early anti-venom administration, as we are all aware, decreases coagulopathy, capillary release, and DIC. Whether this early use of anti-venom can decrease the occurrence of acute or chronic hypopetitism, that needs to be investigated. We need to investigate whether early glucocorticoid in refractory shock in snake bite is beneficial. And because, a lot of patients are in rural areas, so that is very important. We need to recognize chronic hypopetitism early because that is associated with significant mortality and morbidity if they are untreated. Pathogenesis of electrolyte disorders and especially long-term pituitary autoimmunity needs to be determined because they are more speculative. And very important, advances in venom sequencing and next generation proteomics may help to identify venom components that can particularly, we can pinpoint these clinical complications. So in conclusion, acute pituitary adrenal insufficiency, hyperglycemia, hyponatremia, hypokalemia are emergencies which we need to be always keep an eye on in snake bite from endocrine perspective. Pituitary is by far the commonest gland, but adrenal gland is though rare, but rarely affected, but is still important. And adrenal hemorrhage can lead to adrenal insufficiency, and especially patients present with pain, abdomen, and intractable hypotension. We must remember most bites occur in poor, remote, rural areas, so confirmation of diagnosis may not be always possible. So early initiation of empiric steroid, and we can keep the blood before starting the steroid and for proper evaluation. Especially it may be life-saving in patients who have acute hypotension and hypoglycemia, suggesting acute pituitary insufficiency. If polyuria develops after steroid, we need to screen for diabetes insipidus as well. Very importantly, in long-standing patients, this is what they come to us with, that is symptoms of delayed hypopetitism, as we have seen in this presenting case with coming with secondary amenorrhea. They may be very non-specific, suggest chronic ill health. So we need to screen them irrespective of symptoms. And this needs to be, we need to focus on patients, especially those who have developed acute kidney injury, bleeding, and those require a number of hemodialysis sessions, and especially those who have an abnormal whole blood clotting time suggesting DIC at presentation. It is very important to follow them up long term, because as we have seen in Sheehan syndrome, the pituitary damage may be progressive and there can be new hormonal deficiencies, and this may lead to significantly increased morbidity and impaired quality of life. Very important, falling back only on imaging, that's a very important caveat, may be misleading, because even in chronic hypopetitism, the pituitary imaging may be normal. So being aware and spreading the awareness of endocrine complications post snake bite is very important. Especially this has to be spread to the periphery levels, because that is where the snake bite and its complications occur. Thank you very much.
Thank you so much, Demana sir. Mishra sir, can I introduce the moderator? So Mishra sir is on the mute mode. So to take forward the session, which is a panel discussion, we have very eminent endocrinologists there to tell us more about the subject, and to take us through the session as a moderator, we have Dr. Nilanjan Singh Gupta, who's Professor and Head Department of Endocrinology, NRS Medical College, Kolkata. He's also the Honorary General Secretary, Endocrine Society of Bengal. He's the National Advisory Board Member, IGEM, Secretary Board of Studies in Endocrinology, West Bengal University of Health Sciences. He's the coordinator of DDCT course, State Medical Faculty, and has more than 75 publications in national and international journals. Dr. Sen Gupta, may I please ask you?
Thank you. Thanks the organizer for including me in this very exciting session on tropical endocrinology. And I think the stage has been amply set by Dr. Sajal Kamath and Professor Demallo Shannal for an in-depth panel discussion on the nuances of snakebite endocrinopathy. We have a galaxy of endocrinologists in the panel, Dr. Kishore Behra, Dr. Kaushik Pandit, Dr. Pathophysiology Chakraborty, and Dr. Ritesh Agarwal. So let us start with Dr. Kishore Behra. So may I ask you, how common is snakebite endocrinopathy? Meaning that of all patients suffering a snakebite, how many of them would land up with any endocrinopathy? And what would be the relative prevalence of endocrine gland affection?
Thank you for good morning and respected teachers and my friends, and very grateful to be invited for this panel discussion. Actually, this snake bite causing the
Dr.
Am I audible?
You are now audible. Yeah.
Yeah. Actually, the prevalence exactly in India, it's very difficult to say, but it is quite often seen in rural area, and usually most of the snake bites are in India are vasculotoxic and sometimes also neurotoxic. Both can be seen, and vasculotoxics are more prone to induce like hypopetitism and adrenal insufficiency, and neurotoxics are more prone to leads to dysglycemia and hypocalcemia. So around I'm not aware of exactly what is the prevalence of hypopetitism after a snake bite. So that's from my side.
Yeah. So Dr. Kaushik Pandit, may I ask you, we know that the prevalence of snakebite endocrinopathy depends upon the type of envenomation that Professor Shannal has very well elucidated. Can you tell me, does it have any bearing on the age, sex, or occupation of the individual? Means who are more vulnerable? Dr. Pandit, please.
I mean, honestly, the association of snakebite and endocrinopathy is not very well delineated, simply because of the fact that it is not well understood, because most of the envenomation that occurs in the rural areas where many people may not survive to receive the care and the diagnostic modalities that are available to pick up endocrinopathy. So whatever we assess would definitely be an under-reported. It is known that, the snakebite endocrinopathy does not have a very strong predilection with age, sex, etc. Published data from India suggests that nearly 15% are below the age group of 15 years of age. And most of the common people, most of the common age of presentation is from 30 to 70. And is understood that they are the people who usually go to the fields to expose themselves to the risk of a snake bite. So honestly speaking, a clear delineation of the risk factors so far as age, sex are not very clear as far as the data that you have at hand now.
Thank you. Thank you. I have the next question to Dr. Pathophysiology Chakraborty. Now, is it really possible, means general care physicians are dealing with snakebite poisoning in the primary health center, secondary health center. So we endocrinologists are seeing the endocrinopathy part of it. But how can a primary care physician predict that this patient may have an acute endocrinopathy following snakebite, and go for the suggestive tests? So what are the indicators, if any, of acute endocrinopathy following a snake bite?
Good morning. Yeah, it's really difficult to pick up the acute endocrine dysfunction following snake bite by the primary care physicians. So I have worked almost 15 years in one of the peripheral medical colleges of West Bengal, and I have seen a good number of snake bites during those years. So majority of them, they presented with hyponatremia, even with recurrent episodes of hyponatremia. You cannot state that this is an acute manifestation of snake bite, but this is a chronic complications of snake bite endocrinopathy. So as we have learned from Dr. Chanal, that if there is acute hypopituitarism or there is acute adrenal hemorrhage, which may give rise to acute adrenal crisis, which is somewhat rare in snake bite, but acute hypopituitarism leading to acute adrenal crisis, in some cases acute DI, would be the acute endocrine manifestations following snake bite. But having said that, I think it's important for the primary care physicians to pick up chronic endocrinopathy. For an example, they often present with recurrent hyponatremia, secondary amenorrhea, and we have seen patients presenting with recurrent anemia requiring frequent blood transfusion.
No,
Ultimately,
one thing, Partho, may I ask you?
Can I just,
yeah, sure.
The acute presentation can be very varying. I mean, many cases it may be missed simply because of the commonality of the presentation. It can be a recurrent hypoglycemia or resistant hypotension. Other things are not that common.
No, that's what I'm asking, Partho. If somebody is requiring vasopressors or requiring hemodialysis, are they more likely to have a pituitary malfunction?
in that case, we need to follow them up or work them up as the critical care illness associated adrenal insufficiency. So refractory hypotension, refractory shock, not responding to vasopressor, you need to evaluate adrenal dysfunction.
I think these would be the red flag signs for the primary treating physician for seeking the services of an endocrinologist where available.
And in that case, perhaps acute recurrent hypoglycemia is perhaps more common than acute hypotension.
Right. Now my question to Dr. Ritesh Agarwal, shifting from the acute phase to a chronic phase. Now, there are thousands of cases of snake bite occurring in the area. Not everybody is landing up with a chronic endocrinopathy, notably affecting the pituitary. So, how would you suspect, apart from the clinical features which Dr. Shanal has pointed out, which are non-specific, when would you suspect among a population of, say, 1,000 patients who had a history of snake bite, when would you suspect an endocrinopathy on a long-term basis, that is chronic pituitary or chronic adrenal dysfunction, if any, following a snake bite? So what would be the timeline? What would be the suspecting features?
Good morning, everyone, and thank you, Nilanjan Sen-Gupta, sir. So, as we are discussing on the snake's bite, and which is a very important topic in the endocrinology part, and we need to understood and give awareness to everyone so that it can be explored more. So, as sir has told, what is the way we can pick up the chronic history of snake bite patient in terms of endocrinopathy? If I say, if we see the data, the group of patients who have history of AKI at the time of admission, or more history of hemodialysis, or more history of recurrent hypoglycemia, they are more chance to land up in the chronic endocrinopathy out of the snake bite. So as Sanyal sir also told in his presentation, that any of the patients who are coming to your clinic or to the hospital with features of chronic illness or recurrent hyponatremia or recurrent history of hypoglycemia, hypotension, then this group of patients you should evaluate in terms of the dyselectrolytemia, in terms of the blood glucose level, and in terms of the other pan-hypopituitarism finding, especially adrenal insufficiency and pan-hypopituitarism.
Right. Thank you. My question to Dr. Parthopratim Chakraborty, what is the, Dr. Shanal has elaborately discussed about the pituitary dysfunction. Now, can you tell me once again what may be the mechanism of the metabolic abnormalities following a snake bite? What is the pathophysiological mechanisms like dysglycemia or dyselectrolytemia?
Dr. Sanal has elaborated the pathophysiology of the different metabolic disorders like dysglycemia. We can have both hyperglycemia and hypoglycemia. Hyperglycemia is likely a stress response that we see in many cases of stress-induced hyperglycemia. The hypoglycemia is likely due to acute adrenal insufficiency, either primary or secondary. As far as hyponatremia is concerned, Dr. Sanal once again has discussed the role
just
of...
part of one thing. Just I'm interrupting you. Coming to hypoglycemia, that is you are pertaining to that vasculotoxic snake venom mainly.
Right.
Can neurotoxic snake envenomation cause hypoglycemia by way of autonomic dysfunction?
I am not aware of the exact mechanism, but perhaps due to involvement of the autonomic nervous system, defective counter-regulatory response, they may cause hypoglycemia as well.
Right. So please carry on. Yes.
As far as hyponatremia is concerned, it can be the acute hyponatremia can be because of hypovolemic hyponatremia, because of capillary leak, because of significant dehydration, blood loss, and etc. Or it can be euvolemic, as we see in SIEDH. Dr. Sanal has already discussed SIEDH, I mean, because of corticosteroid deficiency and the thyroid hormone deficiency. And Dr. Sanal has also discussed the role of ANP in development of hyponatremia. The other issue is the potassium hemostasis. The hyperkalemia once again can be because of adrenal insufficiency, primary adrenal insufficiency to be more specific, can be because of AKI, which is perhaps more common than primary adrenal insufficiency. Dr. Sanal has also discussed type 4 RTA, that is hyporeninemic hypoaldosteronism, giving rise to hyperkalemia. And having said that, I think the pathophysiology of metabolic disturbance perhaps is not crystallized, but these are the possible postulations by which you may be able to explain both hyponatremia, hypokalemia, hyperkalemia, or even hypernatremia in some cases.
Thank you. Dr. Kishore Behra, so when dealing with a snakebite endocrinopathy, what would be your protocol to find out pituitary dysfunction following snakebite in an acute setting? So acute, how would you go about in establishing, by way of investigations, a diagnosis of acute pituitary dysfunction following snake envenomation?
Yes, sir. Actually, the acute pituitary dysfunction usually mostly we see are hyponatremia and hypocortisolic state mostly, and these two is the most important things to be taken care. And it has been shown that if there is a different cutoffs for cortisol. If if it is random cortisol, some say if it is less than 10, or the delta variation, if it is the difference after giving the corticotropin and it's not rise more than 9, and then or you give the stimulation test, it's not the value not goes beyond 19, so probably we are dealing with hypocortisolic state. So in that case, we have to start IV hydrocortisone 100 milligram. Prior to that, you have to take the blood to assess the other pituitary dysfunction. And sometimes also after when we give the hydrocortisone, then only the DI sometimes sets in. So these are the things we have to take care. This is about the acute. And for
once you have started on glucocorticoid replacement, so how long usually the patients need glucocorticoid support?
Right, sir. So when the patient is very sick, then probably we can continue the hydrocortisone. Then once he or she become able to take orally, then we can substitute to Visalon maybe 5 and 2.5. Then we can recall after 6 weeks, and we can stop and we can reassess the axis again. And because we don't know how many patients will go to chronic uh, adrenal insufficiency, but it's all depends upon if somebody is having AKI or they are having in ICU setting, probably they are more prone to develop chronic hypocortisolic state, and if they are not, probably they can improve.
Right. Now, my question to Dr. Kaushik Pandit. So, as we have understood, finding out chronic panhypopituitarism after snake bite needs a high index of suspicion. And what investigations would you advise to finally arrive at a diagnosis when you are facing such a patient who is complaining of a vague ill health with a history of, say, snake bite 5 years back?
Okay. Published studies had given us some data about the predictors of development of hypopituitarism. And we know from the data published from this part of the country that number of hemodialysis or the surrogate measures of DIC like whole blood clotting time predicts pretty well about the development of hypopituitarism. Now this hypopituitarism can develop in various aspects of the pituitary dysfunction. Some can have gonadotroph dysfunction, some can have corticotroph dysfunction, some can have growth hormone dysfunction and thyrotroph dysfunction. If we go by the data, we know that there are differences of opinions amongst the publication. The commonest probably is gonadotroph dysfunction and corticotroph dysfunction. The other parameters like thyrotroph dysfunction and growth hormone dysfunction are relatively less. And it is known for pituitary dysfunction to be unraveled, it has to be a dynamic pituitary testing in most of the situation. So if we can have an idea about the patient's clinical presentation of requiring multiple hemodialysis or the whole blood clotting time or other features of DIC was there, we should have a clinical suspicion of hypopituitarism in this situation, and we should test all the parameters of the pituitary, preferably in a dynamic situation, to unravel the disease in its entirety.
Right. Thank you. I think we are coming to the end of this session. My last question to Dr. Ritesh Agarwal. So how can you prevent all these things? Means what? The snake bite endocrinopathy, the best thing will be prevention of snake bite. But that is probably not the purview of the endocrinologists. But suppose the patient has suffered a snake bite, what would be our message to the primary care physicians to prevent an acute or a chronic endocrine episode that may even be life-threatening? So what about your early detection and early management issues overall, taking care mainly of the pituitary and adrenals and the metabolic abnormalities that are the most common ones that we encounter?
Yeah, thank you, sir. So as Kaushik sir has also told, we have to be vigilant to see which group of patients will develop the chronic complications or the endocrinopathy, like those who need more dialysis at the time of acute condition, those who require more vasopressor, those who have more whole blood cell clotting time. So these group of patients are keep on vigilant eye, may develop chronic complications of the snake bite like hypopituitarism and adrenal insufficiency. So
do you recommend, I mean to say, in an otherwise asymptomatic patient, do you recommend on a chronic basis yearly endocrine testing?
So not yearly endocrine testing is required to all the patients, but definitely yes, as we know the sign and symptoms of the adrenal insufficiency or gonadotropin deficiency, we may need to evaluate that group of patients, but definitely asymptomatic presentations are sometimes come to us in the form of chronic generalized illness with history of snakebite. If it is there, we need to evaluate specially for the corticotropaxis.
Thank you. Thank you. So to sum up, I think our panelists have done an excellent job in dealing with a topic not quite commonly discussed in endocrine fora, but suffice it to say, snakebite being a common problem in India and related countries, and snakebite endocrinopathy also being not that rare, endocrinologists should have a high index of suspicion, and we should teach our physician colleagues who are in the front line tackling patients with snakebite. As Dr. Debmalla Shannal has rightly pointed out, imaging may be misleading, neuroimaging may be misleading, especially when it comes to the pituitary, both in the acute and especially in the chronic setting. We have to do appropriate hormonal assays and interpret them appropriately, and most importantly, life-saving therapies, especially optimizing dyselectrolytemia and optimizing glucocorticoid deficiency, whether in an acute setting or in a chronic setting, it should be the order of the day to prevent not only morbidity, but also possible mortality coming out of an endocrinopathy due to snakebite. Snakebite itself can be lethal, but many a time if the patient passes of that phase of AKI or massive hemorrhages and DIC, the chronic sequelae can lead to many problems affecting the quality of life. That has to be taken care of with a high index of suspicion. I thank the organizers once again and thank all my panelists, and hand over to Dr. Arundhati Dasgupta for concluding this session and going on to the next session. Thank you.
Thank you so much, sir. That was a wonderful session. And thank you on behalf of Endocrine Society of India to all our panelists, our chairperson, our speaker, and our presenter for the session. We shall move on to the last session of the Tropical Endocrinology Summit. And this session is something which is not usually discussed, but a very, very important topic nevertheless, a topic on research in endocrinology. Research, as we know, is moving from the unknown to the known, about developing newer concepts, about improving the older concepts. And to talk on this very, very important topic, we have an esteemed panel of speakers and chairpersons. So I would like the chairperson slides to be put forward, please. So our first chairperson for the session is Dr. A.K. Baliyar Sinha. He's an eminent endocrinologist and is the professor and head of Department of Endocrinology, SCB Medical College. He is been attached to SCB Medical College and Hospital, Cuttack, Orissa, with an experience of more than 35 years. He's one of the leading endocrinologists of the state and the country. His interests are diabetes, thyroid, hypothyroidism, hypothyroidism, among others. And he was the one who started the DM endocrinology course in Orissa in SCB Medical College in 2012. And he's been working at it for the last 35 years. He's got around 27 scientific publications in international and national journals. Welcome, sir. Our next chairperson is Dr. Shubhankar Chaudhary, who needs no introduction, but he is the professor and head of the department, IPGMR and SSKM Hospital, Kolkata. Sir has a brilliant academic record starting from school leaving examinations, where he secured the second position through MBBS, DTMNH, MD, DM courses with numerous scholarships and prizes, and has been a topper at numerous final examinations at the university level. He also plays an active role in several medical associations, is a secretary of the West Bengal chapter of the RSSDI and immediate past president of the Endocrine Society of India. He has numerous recognitions, and his accreditations include Vice President, Diabetic Association of India, West Bengal, founder patron, South Asian Federation of Endocrine Societies, scientific chairman, first scientific meeting of SAFES, organizing chairman, first international clinical update.
Arundhati, I think we can cut this short. We can go over to the speakers.
Go on to, third chairperson is unfortunately not there. He could not join in. So could we have the fourth slide? Yes, our fourth chairperson is Dr. Ashok Kumar Sahu, and he is a senior consultant and head department of endocrinology. He has completed his MD in general medicine from BHU and pursued DM in endocrinology from AIIMS. He has numerous awards and recognitions. He's been awarded with the Rajdhani Gaurav Samman and the Ekam Rashi Award. So welcome, Dr. Sahu, sir, Dr. Chaudhary, sir, and Dr. Balia Krishnan Sinha, sir. And could you please take it forward from here?
Who takes over? Yeah, Dr. Balia Sinha?
Yeah.
Yeah.
Yeah. So today there are 4 speakers: Dr. Shujoy Ghosh, Dr. Vaibhav Pathak, Dr. Abhavani Baru, and Dr. Salam Ranveer.
And also Professor Satyanath Mukhopadhyay.
Also Professor Satyanath Mukhopadhyay. And I will Professor Satyanath Mukhopadhyay with the speaker, and he is the professor in the Institute of Postgraduate Medical Research in Calcutta, and is prior to his current designation as professor, which took to the September 9. Dr. Mukhopadhyay is held as title of lecturer, assistant professor, and associate professor at IGPGR, and he is the member to many societies, and I invite him to speak on the topic. Please, Dr. Satyanath Mukhopadhyay.
While Professor Mukhopadhyay just gets ready and starts sharing, I just wish to make a comment that more challenging than each of these researchers' job as a researcher to get grants, to get people to do the work, and so on and so forth, to finish projects on time. I think a bigger challenge today is to finish within your time limit. So please try and stick to your time. Thank you, Professor Satyanath Mukherjee.
Good afternoon, everyone. At the outset, I thank the organizers for having me over here.
So full screen, please. Slideshow.
Am I audible?
Yes,
sir.
And can you see the slides?
Yes, sir.
Fine.
Just go into full screen.
Okay. Yeah, that's the
Thanks.
presentation mode now. Disclaimer. I have, first of all, nobody had asked me for my CV slide. I have never done DNB in my lifetime, so I'm not a DNB, just a simple DM in endocrinology. Now, while inviting me for this talk, one of the organizers told me that you have to restrict yourself to 12 minutes and you can discuss 1 paper or maximum 3 papers. Now, our group has been active in this field for more than a decade now, and there is a continuity in the hypothesis that we have pursued over the last decade. So I thought it would be a kind of disconnected if I pick and choose 1 or even 3 papers. So what I will try to do is, keeping the time slot in mind, I will quickly rush you through the kind of work that we have been doing, and in each stage of the hypothesis you will see multiple publications coming up, but I'll be as brief as possible. So adipose tissue lipoprotein lipase is under constant inhibition by insulin in the physiological state. So in someone with insulin resistance, that inhibition is gone. So adipose tissue undergoes excessive lipolysis, and the free fatty acid reaches the liver, and there it stimulates the production of a very powerful hepatokine called phetuin A. This phetuin A then goes on to the adipose tissue and suppresses adiponectin synthesis. And by multiple biochemical pathways, phetuin A also interferes directly with muscle ATP generation. So in one word, it causes mitochondrial dysfunction in the muscle. So the muscle physiology suffers, which translates into or manifests into impaired insulin-mediated glucose and lipid uptake by the skeletal muscles. That in turn results in insulin resistance and type 2 diabetes. So glucose and saturated fatty acids through different mechanisms that increase the production of phetuin A, and at the middle you can see a blown up view of a hepatocyte which increases the output of its phetuin A into the circulation. And phetuin A causes insulin resistance by two important mechanisms. The first is that it's a powerful and direct inhibitor of insulin receptor tyrosine kinase phosphorylation. And the second and more importantly, it induces adipocyte inflammation, which also includes the resident macrophages in the adipose tissue by way of acting as a binding protein to a receptor called toll-like receptor 4 or TLR4. And this has been our area of interest over the last couple of decades. So once TLR4 activation occurs, there is activation, downstream activation of immune cells and adipocytes that release copious amounts of pro-inflammatory cytokines, and that leads to insulin resistance. So here you can see that high FFA in DBDB mice and also in high-fat diet mice, they increase phetuin A, and paralleling the increase in phetuin A, you have an increase in phospho-NF kappa B, which is the downstream mediator of phetuin A action. And you can also, I hope you can see that there is an increase in the protein level of TLR4, not only in the animal models, but also in serum samples isolated from humans with type 2 diabetes. So here you can see clearly, let's focus on the humanoid adipocytes. This is an oil-red O experiment where normal physiologically functioning adipocytes, they pick up lipids very nicely, and you can see the nice red dots that are intracellular lipids. In presence of phetuin A, the lipid uptake is completely abrogated, and here you can see rosiglitazone increasing lipid uptake significantly in insulin-resistant individuals. But so powerful is the effect of phetuin A that when you add phetuin A, this rosiglitazone-mediated lipid uptake is completely abrogated. And as you have a high phetuin A in the system, you can see there is a significant increase in the release of pro-inflammatory cytokines, IL-6, TNF-alpha, and IL-1 And one of the defining features of adipocyte function is insulin-mediated glucose uptake. And here you can see that in the control adipocytes, the glucose transporter 4, GLUT4, they are all taking rest inside the intracytoplasmic vesicles the moment you add insulin or you eat. So under the influence of insulin, there is immediate peripheral localization of the GLUT4, and they are now in a position to take up glucose and ferry it back into the cells. Then you add phetuin A, even in presence of insulin, the insulin-mediated glucose uptake is completely abrogated. So to cut a long story short, excess of phetuin A coming out of the circulation stimulates the production of excess of FFA, stimulates the production of phetuin A. The two form a dimer. Dimer then latches on to TLR4 on the surface of adipocytes and immune cells. And you can see downstream release of proliferative cytokines that lead to insulin resistance. Now, the next question comes, how do the cytokines induce insulin resistance? But let's take you through the publications in Nature and in Diabetologia that discuss this part of our discovery, the phetuine A acting as an endogenous ligand of TLR4 to promote lipid-induced insulin resistance. So in this cartoon, you will see that release of pro-inflammatory cytokines actually stimulates the production of caspase 1 from the inflammasome, and this what this caspase 1 does is it causes cleavage of SARTwin1, and I think you all know that SARTwin1 is a major regulator of mitochondrial ATP production. So once SARTwin1 is cleaved, mitochondrial ATP production goes down, and I request the chairpersons to give me a signal whenever 10 minutes is gone, so I will stop there. So once SART1 is cleaved, you can see that mitochondrial bioenergetics suffers. On the other hand, phetuine A, through its direct action on Wnt3A, it inhibits pipa gamma activation, production of adiponectin goes down. Adiponectin, as you all know, it stimulates the production of AMPK in the skeletal muscle, which is the cellular energy sensor. So once AMPK goes down, you do not have downstream activation of PGC1 alpha and its target genes that are responsible for mitochondrial bioenergesis, biogenesis and bioenergetics. And then so a combination of low SART1 and low AMPK in the insulin resistant state leads to insulin resistance and type 2 diabetes. So these are the publications related to adiponectin suppression and suppression of SART1 and AMPK. So this is the last publication. It came out only last month, where we have been able to show that pipa gamma activation goes down in insulin resistance because of an increase in inhibitory phosphorylation of pipa gamma by phetuine A. And here you can see adiponectin has an inverse relationship to phetuine A. So on the upper right panel, you can see as you increase the concentration of phetuine A in the media, so the adiponectin level goes down, and once you use a phetuine A blocker, you can see there is a progressive increase in adiponectin, thereby signifying improvement in insulin sensitivity. Here you can see in this, this is a co-culture experiment where adipocytes treated with phetuine A, rising concentration of phetuine A, you can see there's a progressive decline in adiponectin, and this is also associated with a decline in mitochondrial ATP production and phospho-AMPK generation. Here in this cartoon, on the top left, you can see that how a lowering of AMPK due to lowering of adiponectin and lowering of SART1 leads to impaired mitochondrial biogenesis, the hallmark being the mitochondrial DNA copy number goes down significantly with increasing concentration of phetuine A, so from 50 to 100 micrograms per milliliter, and this is associated with an impaired mitochondrial ATP production, which leads on to progressive insulin resistance and type 2 diabetes. I'm almost coming to the end of this presentation. And here again, you can see that another influence of phetuine A, there is no translocation of GLUT4 into the periphery. This is a normal adipocyte or normal muscle cell myotube where you can see the cell membrane because it lights up due to accumulation of GLUT4. When you add phetuine A in the muscle, it cannot see the cell membrane at all. Myocyte membrane is not visible because all the GLUT4 they are located in the center. And when you do not have GLUT4 translocation onto the cell surface, glucose level goes up. So here on oral glucose tolerance test, you can see in high fat diet added to phetuine A, there's a significant increase in glucose intolerance in the diabetic range, and the moment you knock down phetuine A, the glucose levels come back to normal. And on the right bottom cartoon, you can see the insulin-mediated glucose uptake in the tissues, and this is impaired in the presence of phenytoin A. As you can see over here, you require a higher level of insulin to affect the same amount of intracellular glucose uptake. And this is again rescued when you add a phenytoin A blocker. I think this is the last slide. So excess of free fatty acid leads to production of increased phenytoin A in the hepatocyte. Then there is a trimerization between FFA, phenytoin A, and TLR4, release of NF-kappa B, then through a series of complex biochemical pathways. At each step, we have one or more publications here, ultimately leads to increase in inhibitory phosphorylation of PPAR gamma at the serine 273 residue. So when the active PPAR gamma goes down, so does adiponectin. In absence of adiponectin, AMPK activation in the skeletal muscle cannot occur. So this interferes with mitochondrial biogenesis and bioenergetics. And here, this cartoon actually clearly, nicely illustrates the adipocyte-myocyte crosstalk that leads to disruption of energy homeostasis, leading to insulin resistance and type 2 diabetes. So to wrap up, excess circulatory free fatty acid releases phenytoin A from the liver. Phenytoin A inhibits insulin receptor tyrosine kinase phosphorylation. In addition, phenytoin A also suppresses adiponectin production by its action on Wnt3 beta-catenin pathway. Phenytoin A, by reducing mitochondrial ATP generation, leads to insulin resistance and type 2 diabetes. I think that is the last slide. So thank you for listening.
Thank you. There should be some questions and answers. We invite any questions to Dr. Satynath.
I don't see any questions yet in the chat box. Can I just quickly, before we go on to the next topic, ask Professor Satynath Mukhopadhyay, who have been really in this field for the last so many years. So do you think that the PPAR gamma activators, which are the usage of which has significantly declined, do you think they should, you want to see a resurgence of them in view of work that you have done?
Thank you very much. This is a very, very interesting question. Actually, the classic PPAR gamma activators like the glitazones, they directly bind to the PPAR gamma classic receptor site, and that leads to more of side effects than physiological effects. So you get the fluid retention, anemia, and so on. So now people are looking into the serine 273 residue downstream, where if you can stimulate inhibitory phosphorylation, then you have insulin resistance, which phenytoin A does. So if you block phenytoin A, or you find out selective PPAR gamma agonists, multiple such agents are now in the pipeline, they all antagonize the action of phenytoin A at the level of serine 273 residue, thereby inhibiting its inhibitory phosphorylation and thereby improving insulin sensitivity, minus the side effects of classic PPAR gamma agonists. Thank you.
Thank you. That was great. Thank you. So we have to move on. And it's my great pleasure to introduce, of course, again, it's like adding coal to Newcastle, Professor Shujoy Ghosh, who is, of course, in our department. So I'm very proud to introduce him in the Department of Endocrinology at IPGME and SSKM Hospital. But of course, he is also, as you all know, the face of the Endocrine Society, being the secretary, very efficient secretary of the Endocrine Society of India. And also, he's the executive editor. Maybe he'll be in the process of transferring charge for our very dear Indian Journal of Endocrinology and Metabolism. So over to you, Shujoy, for the next, 10 to 12 minutes. Professor Shujoy Ghosh may start.
Thank you, sir. Hopefully I'm audible as well as my slides are visible.
Perfect, yeah.
Right. Okay, so after that great talk by Professor Satynath, sir, with regards to research entirely on basic science, I'm going to talk about something that we've managed to do in the department itself in terms of the clinical work, as well as the little bit of basic science that we've actually needed to do for this particular study. So I'm going to talk about plasma cell-free DNA to differentiate malignant from benign thyroid nodules. Now, we are all aware that thyroid cancer is probably the commonest endocrine malignancy, and it's Bethesda 3 and Bethesda 4 that we as endocrinologists are worried about, because we tend to send them to our surgical counterparts who go on operating on them, different kinds of operations. And in some of them, the patients come back with a report of a benign lesion, which then kind of tells us and the patient, why the hell did we do the surgery in the first place? And in the malignant ones, usually the surgeons, because they've taken out only a bit of the thyroid, we ask them to go back to the surgeon for a completion thyroidectomy. So in some cases, we are asking them for surgeries which are not needed, and in others, we are making them undergo 2 surgeries. And worldwide, molecular techniques are being used increasingly in these individuals with indeterminate nodules. Unfortunately, in India, we do not have commercially available methods of these molecular techniques to help us in our day-to-day clinical practice. Now, liquid biopsy is an upcoming branch of cancer genetics, and some of you will be aware of the clinical application of the same in, for example, in lung cancer, in breast cancer, as well as in some of the newer papers on ovarian carcinoma. So this is just a repetition that it's 3 and 4 where we probably need something else in terms of help. Now, just a little bit about liquid biopsy and cell-free DNA, because that would help us understand our study better. When you, for example, stick in a needle into the lesion and look at the cells in terms of cytology or, even histopathology, that's tissue biopsy. But when you take samples not from where the malignancy is, but from somewhere else, it could be blood sample, it could be CSF or elsewhere, and try to look at certain things to predict malignancy, that's called liquid biopsy. So what questions could liquid biopsies possibly answer? It could probably tell us if there is any malignancy. It could tell us whether the malignancy has spread. What genetic changes does the tumor have? Is whatever form of therapy we are giving, is it working? Are treatment working at all? And is there any residual disease or recurrence? Now, this is probably one of the only clinically available commercial kits. This is the COBAS test for the EGFR mutation for lung cancer, which helps not only in the diagnosis of lung cancer, in some forms of lung cancer, but also prognostication and follow-up of patients receiving treatment for lung cancers. And that's currently FDA approved. And liquid biopsy could possibly offer a non-invasive approach for personalized patient care. So, like I said, liquid biopsy approaches could look at various things. You can isolate the circulating tumor cells, you can have exosomes, and you can even look at cell-free DNA released by the apoptotic or necrotic tissues. And it's not necessarily peripheral blood from where you isolate these, it could be from any other body fluid as well. So this is from New England Journal of Medicine a couple of years ago. This particular publication, I think, is something that everyone should read about the clinical application of cell-free DNA in clinical practice of malignancies. So as you can see, liquid biopsies can have from CSF, saliva, pleural fluid, peripheral blood, ascitic fluid, stool, or even urine samples. Now, this cell-free DNA can again be of various kinds. It can come from the necrotic tissues, it can come from the apoptotic tissues, and it could, circulate in the form of free DNA. It could be nucleosome DNA, vesicle-bound DNA, a lot of it. And when we are looking at it, we could look at either the total quantity of cell-free DNA, we could look at specific mutations in the DNA, we could look at integrity of cell-free DNA, we could look at the number of copy alterations, the gene fusions we can look at, and even you can look at DNA methylations. So all of these can be looked at from cell-free DNA, wherever you are taking it from. And the application, I think I've already talked about, for screening, from staging, for spreading, to detect distant metastases, to detect relapses, and also to predict response to therapy. So I'll skip some of these slides because of the paucity of time, but the other thing that you can also look at is when you've isolated the cell-free DNA, you can actually look at the driver mutations of that particular malignancy. For example, here in thyroid malignancy, you can isolate the cell-free DNA, and whatever mutation studies you were looking at, say FNA material, you can try and see whether those same mutations are present in that cell-free DNA or not, because then that gives you greater confidence that this cell-free DNA's origin is actually the tumor tissue. And this is something that I've said. If you look at, say, for example, an FNAC and find someone's got a papillary thyroid CA, it's something that you'll probably get to see only once at the time of diagnosis. But thereafter, if you're trying to figure out, has this patient responded, you might not get any more tissue to look at that mutation. But whereas if you look at peripheral blood and you look at cell-free DNA, you might be able to see whether the cell-free DNA levels are rising again, whether the mutation is again present. So this would be more of a dynamic monitoring of cancer compared to a snapshot monitoring from a tissue diagnostic test. So this is the summary of what I've talked about in terms of cell-free DNA, the origin, the definition, how to collect it, the advantages, and of course, certain disadvantages as well. So with that in mind, we essentially embarked upon a study to try and see whether cell-free DNA concentration itself could help tell us that is this thyroid nodule whose Bethesda report has come back in the indeterminate category benign or is it malignant? So like, traditionally what you and I would be doing, once we find someone's got a thyroid nodule, you've asked for a thyroid function test, you've asked for an ultrasound of the thyroid, done a TIRAD score, and depending on the TIRADs being more than 2, you've undertaken US guided FNA. Additionally, what we've done is we've taken a peripheral blood sample and we have isolated cell-free DNA from that sample, and we've measured the concentration of cell-free DNA. And we've then gone on to try and predict. So this is a very, very busy slide, but what I would try and explain in a very brief manner is we've tried to color code this table. So the top half, which is in white, is the number of patients. And I've told you we've done a thyroid function test, we've done a thyroid ultrasound, and we've done a thyroid ultrasound guided FNA and gone for a Bethesda classification as well as a thyroid. And we've also measured the cell-free DNA. We've had to exclude people wherein if you had any history of previous malignancy, if you had previous history of currently ongoing infection, inflammation, multinodular goiters, we actually excluded all of them. And then we categorized individuals into 3 groups. One group is Bethesda 2, which we assumed is as benign. The second group is Bethesda 5 and 6, which is where we think most of our malignancies would be. And the third group, which is on the right-hand side, includes Bethesda 3 and 4. Now, in the Bethesda 2, only the ones where it was clinically indicated, they underwent surgery, and histopathologically, it was confirmed that they were indeed benign. The rest, we presumed were benign, those who did not undergo surgery. The Bethesda 5 and the Bethesda 6, all of them underwent surgery and had a histopathological diagnosis of malignancy. So now you have 2 groups of people, one, the benign ones and the confirmed malignant ones. And we looked at their cell-free DNA levels. As you can see, in the benign ones, it was around 22, and in the malignant ones, it was around 96. So we did an ROC curve, which had an area under the curve, which was very, very good, of 0.992. And we came up with a cutoff, which was 67.9 nanogram per ml, which we felt from this ROC curve had a sensitivity of 100% and a specificity of 93%, because essentially we do not want to miss a single case of malignancy. Now, in the right-hand side of this PowerPoint presentation, you see you've got patients who are in Bethesda 3 and 4. Now, we had also looked at their cell-free DNA levels, but according to standard currently existing protocols, we subjected all of them to surgery. And following surgery, they had a histopathological diagnosis, whether they were benign or malignant. Now, when we use this cutoff, which we had derived in the left-hand side, and tried to predict whether that cutoff was able to predict malignancy in this indeterminate group of patients with thyroid nodules with Bethesda 3 and 4, we can see that that cutoff predicts malignancy with 100% sensitivity and 92.3% specificity. And when you're trying to look at agreement, that means, for example, can this cell-free DNA cutoff replace histopathology? The statistical test that you do is called what is called a Cohen's kappa. Any value more than 0.7 is considered to be good. Any value over 0.8 is supposed to be thought to be very good, and anything more than 0.9 is almost a gold standard. And the Cohen's kappa in our case was 0.94, telling us as if this cutoff was as good as histopathology in telling us whether this is malignant or not. Now, I'll probably skip this slide because this probably doesn't have that much of an important message. But what we did next was every patient who had malignancy and who underwent surgery, we already knew their baseline cell-free DNA level. So 2 weeks after surgery, we rechecked their cell-free DNA levels. And we find that the cell-free DNA levels have gone back to the levels of individuals who did not have cancer. So telling us that the source of the cell-free DNA is most likely the thyroid nodule, because after the removal of that, it's come back to normal. So that's the next thing that we did. And what we did also was, from all the FNA samples, we tried to look at these 7 mutations. So we had a total of about 37 patients who had malignancies. And out of 37, we found that from the plasma as well as from the FNA material, we were able to detect these mutations. So first I'm showing the plasma data. So out of the 37 mutations, malignancies, 31 of them had the mutations isolated from the cell-free DNA in the plasma that we took, telling us that the source of the cell-free DNA is indeed the malignancy. And that we found in 33 out of those 37 when we looked at the FNA material. So essentially telling us that from the cell-free DNA, we can also detect the so-called driver mutations of thyroid cancer. The other interesting thing was, now from the cell-free DNA levels, could we predict the stage of thyroid cancer? Could we tell that, whether there was lymph node involvement, whether there was lymphovascular invasion, capsular invasion, or extrathyroidal extension? The basic premise here is, the higher the load of malignancy, the greater is going to be the level of cell-free DNA. So not only were we able to predict that cell-free DNA tells us that there is malignancy, even within that high level, if you subcategorize them according to the levels, higher the level was, the greater the TNM staging was. So once we have a bigger cohort, we will probably be even to predict that if it's over this level, it's going to be TNM stage 1. If it's going to be above this level, it's going to be TNM stage 2. What we find is there is difference, but this study is not powered to make that statement that, if it's, for example, we are saying if it's above 69.7, it's malignant. But if you look at bottom of the slide, if it's above 69, it's stage 1, up to 69. If it's above 87, it's probably stage 2. And if it's above 94, it's probably stage 3. So we are fortunate that this article has got accepted for publication in Journal of Clinical Endocrinology and Metabolism. Hopefully in the next month, it's going to be the lead article with an accompanying editorial that is going to come out. And if I just again summarize from our publication, the bottom line is there was very strong agreement between cell-free DNA based classification with histopathology based classification of benign and thyroid nodule, and plasma cell-free DNA estimation could help differentiate malignant from benign thyroid nodules. So, and we also plan in future whether we can detect recurrence of thyroid malignancy from reappearance or rise of cell-free DNA. That's something that we are going to do. We are also looking at certain microRNAs and long non-coding RNAs in this particular group of people. Of course, I would acknowledge my department for the constant help and support, Endocrine Society of India and Endocrine Society of Bengal for funding our research project, and of course, Shushmita, who's my PhD student, Shoham, my DM trainee, my colleague, Professor Dr. Pradeep Mukhopadhyay, and our basic scientist, Professor Nitai Bhattacharya for all the help and support, without which I think this study would never have been completed. Thank you very much.
Thank you very much, Shujoy, and congratulations to you and your team for the wonderful work that you have done. I had a small question. When we are talking of concentration of cell-free DNA in plasma, would systemic inflammation be an important confounder? Of course, in your patients you didn't have, but so what are the levels of cell-free DNA that you could get if you had severe inflammation?
Right. So if we look at the exclusion criteria for a study, very rightly you have said, infection, inflammation, trauma, other malignancies, all of this can give rise to rise in cell-free DNA levels. We actually did not look at those category of individuals. We had another third group of people who are the so-called normal controls. Now, if you look at the benign ones, we had levels somewhere around 19 to 22. That was the kind of levels. In the normal people who did not have thyroid nodules, our levels came somewhere around 16 to 17. These are people who did not have. So one of the limitations would be any background inflammatory state, any infection, any major trauma would give rise to increased cell death. That would lead to increased cell-free DNA levels. Having said that, when we looked at post-operatively, we looked at 2 weeks. Now, that itself I thought was too early, but we did it because there were references from one lung cancer paper that you're supposed to do it, even if you do it within 2 weeks, things are fine. We were worried that we might have lost the patient. So we kind of, went for that 2 week, and it was pretty good actually.
Yeah, good. Thank you very much. And I'm apologize to the organizers that, and I've been warned that we're already running 15 minutes late. So can I hand over to Professor Abhay Shahu to take over from me and introduce the next speaker. And of course, I'm sure Abhay has not got an affidavit done and changed his name to Ashok Kumar Shahu, as was shown in the introductory slide.
Yeah, that's okay, sir. So, our next speaker is Dr. Vaibhav Pathak. He's a DM training student from SU Medical College, SU Medical College, Kotak. So, Dr. Vaibhav will present his paper. So, I request Vaibhav to start his presentation.
Is my slides visible?
Yes, yes.
So am I audible?
Yeah, fine.
Yes, sir.
Make it full screen.
Yes, sir. Good afternoon, respected eminent faculties and respected chairpersons. At the outset, I would like to thank my department for giving me the opportunity to speak among such eminent speakers. And I'll be discussing about the data which we have generated to distinguish the idiopathic hypogonadotrophic hypogonadism from CDGP and the accuracy of various serum and urine tests. As we all know that puberty is a complex process which marks the transition from childhood to adulthood. And generally, normal age of puberty, it varies from 8 to 13 years in females and 9 to 14 years in males. And delayed puberty, which is defined as the puberty which is not been attained, the secondary sexual character has not been attained even in females by 13 years of age and in males by 14 years of age. And if we talk about in clinical practice, the common causes which we come across for delayed puberty, which the child would present in the OPD or in department, would be CDGP, hypo, and hyper. It is easier to differentiate hyper from hypo on the basis of basal hormones only. But the dilemma for distinguishing the CDGP and hypo is difficult. The various things which has been proposed starting from history as well as clinical examination, which do help us in distinguishing these two entities, that is CDGP and hypo. For example, being family history being present in majority of the patients with CDGP, but even in 10 to 20% of the patients with hypo, they can have history of delayed puberty in the family members, as well as clinical examination, for example, a testicular volume, which would be slightly on the higher side in patients with CDGP compared to the patients with hypo. But at the end, we do need the help from the biochemical investigation to reach a definite conclusion. So we tried to study the sensitivity and specificity of the various hormones like basal hormones, LH, FSH, inhibin B, and post-GnRH agonist stimulated LH, FSH, and post-HCG testosterone levels in alone or in different combinations. So as we can see at final diagnosis, in which the patients were either followed up for 4 years after the recruitment to the studies, recruitment into the studies, or they had during the follow-up, if their testicular volume crossed more than 8 cc's, then we classified them at CDGP, not hypo. So you can see that the basal inhibin levels were significantly higher in patients with CDGP compared to the patients with hypo. And similarly, comparison of basal hormones as well as the 3-hour post-leuprolide stimulated hormones, it was significantly higher in patients with CDGP compared to the idiopathic hypogonadotropic hypogonadism. Regarding the basal testosterone level, it was not different between the CDGP and the hypo group, but the 72-hour post-HCG testosterone levels was it was higher in patients with CDGP compared to the patients with hypo. And regarding the various hormone levels and their performance as a diagnostic modality, regarding the area on the curve, we can see that the basal inhibin B as well as the post-leuprolide LH and 72-hour post-HCG testosterone, they had significantly higher area under the curve compared to the other parameters. And we devised a cutoff of basal inhibin B as 105 pg per ml, because if you look at the studies previously, there is again a controversy regarding the exact cutoff which should be taken for basal inhibin B. Some have suggested 35, some have suggested more than 100. But again, the lower it is, the more chances that patient would go into a hypo category rather than CDGP. Regarding the accuracy of the various parameters on these cutoffs, basal inhibin B at a cutoff of 105 pg per ml, it has sensitivity of almost 100% with a specificity of 83%, and stimulated values of 3-hour post-leuprolide LH had also sensitivity of 100% with a specificity of 95%. Regarding the combination of the different parameters, we can see that the combining basal inhibin B with the basal LH had sensitivity and specificity of 100%, as well as similarly basal LH as well as post-leuprolide LH had a combination of these two tests had sensitivity and specificity of 100%. So as from this study, we can say that the basal LH cutoff of 0.565, and if you see the Western data, they give a cutoff of slightly lower LH, that is 0.2, 0.3, because they are now using the pediatric higher ultra sensitive assays, but still in our country, the pediatric assays are not widely available. So from this study, we can say that the cutoff is of LH of basal LH 0.565 and a basal inhibin of 105 pg per ml had sensitivity and specificity of more than almost 100%. And the combination of basal LH as well as GnRH agonist stimulated LH also had a sensitivity and specificity of 100% with a cutoff of 0.65 and a stimulated LH cutoff of 6.16. So it is in clinical practice, it's important to combine different tests to increase the diagnostic accuracies and to reach a definite conclusion. And reaching a definite conclusion is important because at this point of time, when the patients present to us, even the parents would be having a lot of anxiety that what will be the prognosis of my child. So on the basis of these tests, we can at least give a idea to the parents regarding the further prognosis. But again, the gold standard being that patients has to be followed up till 18 years, then only we can conclusively say that whether they are idiopathic hypogonadotropic hypogonadism or CDGP. Again, another study we tried in which, as we know that the gonadotropins are secreted in the pulsatile manner, initially when the child starts entering into the puberty, and the GnRH agonist, GnRH axis, as it gets activated, it starts secreting the pulsatility increases mostly to begin with at the night. So first void urinary gonadotropins, they can reflect the pulsatile secretion of the gonadotropins throughout the night, and it may be a better marker of pubertal status similar to the serum gonadotropins. And there is enough data from Western literature that Western countries that and this is the study which has been published in JCM, and they have seen that the urinary excretion of FSH LH in children and adolescents with normal and early puberty, the urinary parameters performed equally well compared to the serum parameters. Similarly, one more that study in the hormone research in pediatrics, which was published, and they said that the first morning voided urinary gonadotropins measurements can be an alternative test to GnRH agonist stimulation test, because these tests are invasive and the urinary parameters, it has more acceptability in children because of the invasive nature of the stimulated test. So in this study, as what we generated the data was that we can see that there was a significant correlation between the urine LH with the basal LH as well as the post-triptolin stimulated LH with a Spearman correlation coefficient of 0.834 and 0.827. It is significant p-value. And similarly for basal FSH as well as stimulated FSH, there was significant correlation between the urine FSH with these basal FSH value as well as the correlation of the urine FSH with the serum stimulated FSH with the significant p values. And this is to show the area under curve for urine FSH and urine LH for differentiating CDGP from the hypo. And there is a significant high urine area under the curve for urine FSH as well as for urine LH, that is being 0.967 for LH and 0.938 for the FSH. And on the basis of this area under the curve, we devised various cutoffs with a different sensitivity and specificity. And we can see this from table that urine LH of more than equal to 0.5 had a sensitivity of almost 96% with a specificity of 85%. And similarly, a cutoff, if you use a cutoff for urine LH of 0.81%, with it had a sensitivity of 85% with 100% of the specificity. And similarly, urine FSH, if you see the various cutoffs and their sensitivity and specificity, so a cutoff of more than 1.35 had a sensitivity of 96.2%, as well as it has specificity of 75%. So just to summarize these two papers, and that the CDGP versus hypo is a common encountered conditions in the clinical practice, and it is important for us to make a definite diagnosis, and as well as that helps us in allaying the anxiety of the parents as well as the patient. So the various non-invasive strategies which can be used for reaching a definite conclusion can be a basal LH, a basal inhibin B, and the urine LH, which can help us in reaching a definite conclusion that this patient can be CDGP or a hypo. Thank you.
Thank you, Vaibhav. So normally in our clinical practice, there is definitely, we feel a lot of anxiety whenever we discuss specifically hypo versus CDGP. So always it's anxiety for the patient. It's also anxiety for the treating physician. What you are going to give a clear-cut answer to the parents. So definitely, Vaibhav, your papers will definitely help us to make some judgment regarding how early you can differentiate particularly hypo versus CDGP. Thank you, Vaibhav. So our next presentation, I'm actually requesting Professor A.K. Balyarsina sir to for the next session. I'm handing over for the next session.
Our next speaker is Dr. Abhamani Baro. Can I have his sleeve slides?
Sahar.
Okay. Sorry. Dr. Abhamani Baro Agarwal, the present designation application is a consultant endocrinologist to Pathika Hospital, Guwahati, the faculty Guwahati Medical College and Hospital, Assam. The total clinical academic experience is above 10 years, and he has many publications in national and international journal. Dr. Abhamani Baro, please.
Thank you, sir. Thank you, respected esteemed chairpersons and distinguished speakers. Thank you for giving me this opportunity. I forward my thanks to the ESI team for giving me this opportunity today. So I'll be talking about one of my studies, that is the phenotypic and metabolic characteristics of young PCO subjects from Assam. So this study was done under the guidance of Professor Dipti Sharma Madam, Professor Uma Kaimal Saikia Madam, Dr. Vipul Chaudhary, Dr. Ashok Krishna Bhuya, and Dr. Vidarvin. So PCOS women of different ethnicity, they present with different clinical presentation. Again, Indian population we know is a mixture of diverse ethnicity. The PCOS phenotypic features, they may differ from one region to another, especially in Assam, which is India in miniature. So we get different mixtures of different races in our part of the country. Also, PCOS belonging to the tribal communities of Assam, they are Mongoloid in origin and different from others. Therefore, it is necessary to understand the phenotypic expression of PCOS from this region to decide the effectiveness of drug treatment in these patients. So the aim of this study was to assess the phenotypic and metabolic characteristics of the young PCOS subjects from Assam. This was a cross-sectional cohort study, and the study population were women with newly diagnosed PCOS treatment naive and aged between 15 to 25 years from different communities of Assam, and we included Brahmins, Dalitas, and Assamese tribal populations. that is Boros, Missing, Rabha, Karbi, and Ahom. The study duration was from November 2015 to May 2018, and patients were selected and from the OPD, Department of Endocrinology at Guwahati Medical College and Hospital, Guwahati. Ethical clearance was taken and it was a self-funded study. So the diagnosis of PCOS was done according to the modified Rotterdam criteria, and we considered oligomenorrhea as less than 8 cycles per year or menstrual interval of more than equal to 35 days. Hirsutism was considered as modified Ferryman-Galloway score of more than equal to 8, and hyperandrogenemia was considered with a total testosterone of more than 16 nanogram per DL. PCOS again were divided into different phenotypes. So we considered 4 phenotypes, that is phenotype A, which included ovulatory dysfunction, hyperandrogenemia, or hypoandrogenism plus polycystic ovarian morphology. Phenotype B is the ovulatory dysfunction plus hyperandrogenism. Phenotype C was the hyperandrogenism plus polycystic ovarian morphology, and phenotype D was the normoandrogenic, which included ovulatory dysfunction plus the polycystic ovarian morphology. Thyroid dysfunction, hyperprolactinemia, Cushing's, non-classic CH, androgen secreting tumor, or use of OCs or any hormonal therapy in the last 6 months were excluded. So anthropometry, BMI, waist-hip ratio, blood pressure, hirsutism scoring was done. Ultrasound, transabdominal ultrasound and carotid intima media thickness was assessed. Blood investigations like OGTT, oral glucose tolerance, fasting insulin, fasting lipids, LHFSH, total testosterone were assessed by electrochemiluminescent immunoassay. Hyperandrogenemia, as I have already told, was considered when total testosterone was more than 16 nanogram per DL. HOMA-IR was calculated, and metabolic syndrome was defined as 3 out of the 5 risk factors like waist circumference more than 88 centimeter, low HDL of less than 50, or hypertriglyceridemia, that is TG is more than 150, hypertension with a blood pressure systolic of 130 millimeter mercury, or a diastolic blood pressure of more than equal to 85 millimeter mercury, and fasting hyperglycemia with fasting glucose more than equal to 100. Diabetes and prediabetes were defined according to the ADA classification, and statistical analysis was done by the SPSS at 620. We could collect 209 patients. The mean age was 21.85 years with a range between 15 to 25 years. The mean age of menarche in these patients were 12 years. Oligomenorrhea was the most common presentation, present in 87.5%, and family history was present in 25% patients. So as you can see, the oligomenorrhea was the most common. Hirsutism was present in 52%. Almost 87% patients, majority were obese PCOS patient. Prediabetes was present in 54%. Diabetes was 21%. Dyslipidemia quite high in our region, that is 78%. And very strikingly, the metabolic syndrome in prevalence was very, very high in our patients. That is, it was present in up to 68%, whereas in other studies, it is up to 35%, which has been reported. So as you can see, the baseline characteristics from our study, the mean age 21.85 years, the BMI, mean BMI was 27 kg per meter square, the mean CIMT was 0.6 millimeter, the mean waist circumference was 95 centimeters, and as you can see, the FG score mean was 8. The total testosterone was 68. And HOMA-IR, the mean HOMA-IR was 3.8. So the phenotypic presentation in our study, we found that phenotypic D was the most common phenotype in our population. It consisted of about 47.5%, followed by phenotype A, which was 35.4%, then phenotype C, 12.4%, and the least present was the hyperandrogenic type, that is phenotype B, which is present only in 4.7%. So we actually compared the different phenotypes of our patients, of all the 4 phenotypes, phenotype A, B, C, and D, and we have found that presentation in the classical type, that is phenotype A, was much earlier. It was at 21 years. Then the waist circumference was significantly higher in phenotype C and phenotype A. The CIMT was significantly higher in phenotype B and C. Then the number of cycles were lowest in the phenotype B. Then the FG score was significantly higher in the B and C. Then the total testosterone, which again correlated with the hirsutism, it was also high in B and C. But strikingly, the insulin resistance, that is the HOMA-IR, was highest in A, followed by the C. So the prevalence of metabolic syndrome was very, very high in our study, with the highest prevalence in A, followed by D, then C and B. And insulin resistance was highest in phenotype A and lowest in phenotype D. So we compared the CIMT and with the total testosterone, we correlated and we found a positive correlation with the total testosterone. So higher is the total testosterone, higher was the CIMT. So the CIMT was highest in B and C and lowest was in the D group. So in the review of literature, the most common phenotype in our study was phenotype D, which is discordant with other Asian and European studies, where phenotype A is reported to be the most common phenotype. And in this study by Sachdeva et al. Published recently in 2019, the most common phenotype was A, followed by C, then B, then D. But in our study, B was the least common phenotype. Again, when we compared the CIMT with the study which was done in South India, then we have found that the mean CIMT was somewhat a little bit higher, that is 0.6 millimeter in our study as compared to 0.5 millimeter in the study from the South Indian population. Again, there was when we compared our data with the study by the famous Ghani et al. Study, which was done in the population from Delhi and Srinagar, we found that the post-load insulin was somewhat higher compared to the Ghani study. And as a result, the postprandial blood glucose, fasting blood glucose were also higher in our study as compared to the Ghani et al. Study. The HDL was also lower as compared to Ghani study. And as you can see, the total testosterone and the FG score was lower as compared to the study found in the Ghani et al. Study. So the differences in phenotypic expression may be contributed by different genetic, social, and environmental factors. And because normoandrogyny phenotype is the most common phenotype, so normal testosterone levels does not rule out PCOS in our population. Also, high prevalence of metabolic syndromes in our studied population suggests that our population are more prone to metabolic consequences of PCOS even at an early age, and early screening is necessary. Also, large-scale follow-up studies are required to understand the metabolic patterns better, and head-to-head comparative study between different racial groups are very important, especially in our region. So again, we are doing a study. This study is undergoing, and we are assessing the effect of metformin on metabolic parameters of PCOS, where metformin are being given. We have almost done with almost 59 patients, and we have seen that treatment with metformin 1500 milligram significantly improves the metabolic parameters, number of cycles, hyperandrogenism after 12 months of treatment. So again, this is an undergoing study. So to conclude, metabolic parameters and metabolic abnormalities are a significant finding in the patients, especially in our parts of the country. Thank you so much.
Thank you, Abhavani, for your excellent presentations and a very good study. And that in India, there are many places the study is going on. And can you say, is there any mixture of adrenal etiology with ovarian etiology? Because you have seen many patients very subclinical CH or very mild CH, they may present with features like PCOS. How will differentiate between those two PCOS and that group?
Yes, sir. So in this study, we have actually ruled out the non-classic CH patients by doing a 17-OHP or an acetate stimulated 17-OHP if their 17-OHP were higher at baseline, because PCOS will also have some increase in 17-OHP total testosterone. So patients who had a 17-OHP at least more than 2, so in those patients, we have done a acetate stimulation test. And by the time this test was done in 2018 and 2016, that time we had actually ACTH available with us. So we had ruled out NCH during that time.
Okay. Any other questions from the audience? Professor Subhankar, please unmute your mic.
thank you very much, Abhamani, for wonderful work that you are continue, and it's of course heterogeneous. Only issue is if you look at the Androgen Access Society for their definition of PCOS, then large numbers of your patients will not at all be diagnosed as PCOS.
Yes,
but
sir.
Anyway, yeah, good. So can we go on to the last but no less the important the topic, and we invite Professor Salam Ranveer, our very good friend, who did his DM from the prestigious All India Institute of Medical Sciences and is on the faculty in the Department of Medicine in the Regional Institute of Medical Sciences at Imphal, and he will be talking on their work on thyroid. So over to you, Dr. Salam Ranveer.
Thank you, respected sir. First of all, I'd like to thank the organizers for inviting me to present our work on the thyroid disorders, which we have done. And I've been told that I can present 5 topics by Dr. Sunil Kota. So I'll be hurriedly talking on the 5 studies.
Yes, and it's unfair to you because you're coming last, but we are already on borrowed time. So please try and keep within 10 minutes. Yes.
Yes, I'll try that. So first I'll be talking about the pregnancy and thyroid, which we have published. And we all know that, we all know that ICG increases after fertilization and peak around 8 to 11 weeks. Thereafter, it decreases, but reduces. And because of that, there is an increase in T4, T3, and TSH is appropriately reduced. And in 10 to 20% of normal women, TSH are transiently low or undetectable. And this is the slide which I've taken out from Explorer Williams. We see an increase in total thyroxine binding globulin by around 10 weeks of pregnancy and plateaus. The total T4 level also picks up and plateaus, and ICG goes up, and there is a corresponding decline in TSH. So because of this, the American Thyroid Association has proposed that gestation-specific pyramid thyroid profile should be established for its population from different laboratories. So we have tried to propose the reference guideline for a woman in Manipur, and we did that by excluding patients with history of thyroid illness with hyperemesis gravidarum or those on taking thyroid-related medications or any other medications that can affect the thyroid function. We also exclude patients with history of established thyroid disorders or any other autoimmune disorders or presence of goiter. And we calculate our sample size based on the previous study by Dr. Marwa, which was one of the earliest paper in India, and we come out to the number 89, 87, and 89, but we still went on with around 375 patients. And this was what we presented in the American Thyroid Association meeting in 2011 at California. We found that in the first trimester, the range was TSH range was from 0.18 to 5.06. In the second trimester, 1.04 to 4.53. In the third trimester, 0.599 to 0.99 to 5.15. We thought this was too high because at the time the cutoff for the American Thyroid Association was 2.5 in the first trimester and 3 in the second and third trimester. And we look at various papers and we saw that the raw value for TSH is not bell-shaped. So we usually do log transformation, and with log transformation, they yield better report. And this is what is shown in the studies published in JCM, that there is a skewed report which will plot the TSH, and after log transformation, it looks more like the normal Gaussian curve. So that's why we do the log transformation of our population, and then we come to a value of 0.21 to 1.82 in the first trimester, and the second trimester 0.71 to 1.71, in third trimester 0.7 to 1.93, which we published in the IGM 2016. Then we came across a paper where they presented about a misclassification of thyroid function values if we take the non-reference interval. So following this paper, again, we'll have a relook at our data, and we published this in a Thyroid Research and Practice in 2015, where we found that if we look at the laboratory cutoff, which is based on a non-pregnant level, we'll be misdiagnosing around 30% of the patients. Then we had a small paper which we did in thyroid dysfunction in HIV-infected children, because thyroid dysfunction has been reported by various studies in the children, and it can contribute to growth failure, and therapy with L-thyroxine results in improvement of height. But at the time when we were searching for literature in India, there was no paper published in India as in the PubMed Index journal. So we decided to undertake the study in our HIV children. So we took around 60 patients who were diagnosed and were treated as per as a NACO guideline of 2006 at that time. So 30 children with minimum therapy of 6 months on ART, and 30 children who were ART naive. We found no difference in the overall prevalence of thyroid dysfunction between those who are with or without heart, but there was an inverse correlation between serum TSH and CT4 count, showing that the probability of thyroid dysfunction decreases as the CT4 count decreases or as the disease progresses. This is a table showing no difference in the total number of patients having thyroid dysfunction, but we see more sick thyroid patients or hypothyroid in the heart group. And we look at the mean TSH and the T3, T4 level, we don't see any difference. Then come to about the thyroid dysfunction in type 2 diabetes patients. This study we undertook because we found several reports of increased prevalence of thyroid dysfunction among patients with type 2 diabetes, ranging from 9.9% to 48%, depending on the definition used for the thyroid dysfunction and on the presence of thyroid autoimmunity. And we carried out this retrospective study in our population of 202 type 2 diabetes patients, around 61 males and 141 females, around 5 years duration of diabetes. And around 68% of them are euthyroid, around 16% were having subclinical hypothyroidism, 11% had clinical hypothyroidism, and 2% had subclinical hyperthyroid, and 1.5% are hyperthyroid cases. So there was a high prevalence of thyroid dysfunction, around 31% in our population. And most of the patients who were detected to have thyroid dysfunction were in the age group of 45 to 64 years. And prevalence was higher in females and in participants who had a BMI higher than 25. So lastly, again, we look for any correlation between BMI and thyroid stimulating hormone, because there are several studies done across different parts of the globe showing that there is a positive correlation. Then again, there are data showing there is no correlation. We look at a Danish thyroid study. They have shown a positive association between BMI and categories of serum TSH, and they found a negative association between BMI and categories of pre-T4. But then we also come across studies showing that there is a correlation between BMI and TSH does not exist in neither euthyroid nor hypothyroid individuals. And another paper showing there is no association between thyroid hormone function and obesity and weight gain. So this study was undertaken in patients between 18 to 65 years who had documented or newly diagnosed hypothyroidism, whether they are treated or untreated, and documented or newly diagnosed subclinical hypothyroid. The exclusion criteria was any endocrine disorders that could affect the BMI. So other than controlled diabetes for at least 3 months, all other endocrine disorders were excluded. Hyperthyroidism was excluded. Pregnant women were excluded, and those with significant renal, liver, or heart disease were excluded. And medications that can disturb the thyroid function or can lead to weight changes were also excluded. We included 318 individuals, and 22 of them had subclinical hypothyroidism, 208 had hypothyroidism, and 88 were euthyroid. So if you look at the BMI category across a subclinical hypothyroid and euthyroid, there was no difference in the BMI 25.5, 26.2, and 25.6, so there was not much difference, whereas there was huge difference in terms of the TSH among the hypothyroid group. The mean was median around 11.2, whereas in the subclinical hypothyroid is 6.8 and the euthyroid is 2.6. But look at the regression, and we find no difference between the 3 groups. Thank you.
Thank you, Dr. Ranbir. I think those were very down-to-earth questions that you took up and tried to provide an answer to, which have a very practical implication in our daily clinical practice. Thank you very much. And I think before I hand it over back to Arundhati or Professor A.K. Baliasina to wind up, I think it's been very satisfying to note, especially for maybe an old person like me or someone who is growing old, is that there is so much of enthusiasm in terms of research in the East, and it's not just reflected in the very senior professors, but less senior professors, and also very importantly amongst the trainees and junior level consultants also. So that's very encouraging, and also that it ranges from from not only direct clinical issues to very basic areas as well. So with these few words, I would like to thank and congratulate all the speakers for the excellent work that they are doing and keeping the flame of learning and relearning, of finding new things in the East alive. And so shall I hand it back to Arundhati?
Thank you so much, sir. Thank you so much. So with that, we come to the end of the 1.5 day long session on tropical endocrinology. It has been a wonderful walk across all the problems of tropical endocrinology, right from malnutrition to infection, disorders, Fcpd, snake bite, and also the very interesting session on the new researches that are being done very much in our own East. So to wind up the program, I'll now call upon Dr. Sambit Das, who's the organizing secretary, to give his vote of thanks on behalf of Endocrine Society of India East. Dr. Sambit.
Thank you, Arundhati. A very good afternoon, everyone. And as it is told, every good thing has an end, and we are at the end of the ESI Digital Symposium for today, and it was quite fruitful. And at the outset, I must thank ESI, especially Ganapati sir and Shujoy sir, for giving us the opportunity to conduct this type of symposium in East. And sincere thanks to Dr. Balyar Singh sir and Subhankar Chaudhary sir for spearheading the entire digital meeting. And I'm really thankful to you both. The scientific program has been nicely crafted, discussing many common yet very less commonly discussed topics, which are relevant in our topics. And many times we forget about discussing these topics. And Sunil and Somik has actually done a great job in formulating the entire agenda, obviously spearheaded by Chaudhary sir and supported by Arundhati. And 3 cheers to all of them. Thank you, Santosh Singh sir, Abhay sir, Manas Barua sir, Jayasri ma'am, and Dr. Kannur for always being there at the time of need. And my sincere thanks to all the faculty members, moderators, panelists for giving their precious time and wonderful deliberation. Dr. Arundhati and Dr. Nilakshi have done a great job as coordinators for the entire program, and I thank both of them. My sincere thanks to Mr. Mintu, who is in charge of the ESI digital platform, Mr. Rabindranath, Mr. Gagan Atreja for all the operational support. And last but not the least, my sincere thanks to all the doctors who have logged in and made it interactive, and hope the meeting might have helped you in to some extent. So thank you again. Long live ESI.